Clock, so I'm going to make a start of the evacuation procedure. Fire drill is not expected, so if the alarm sounds, please evacuate the building quickly and calmly. Please use the stairs and do not use the lift. Once outside the building, please gather outside the Yorkshire Bank on the opposite side of the road. Exit by the door which you've just entered by. If you need any assistance in evacuating the building, please note yourself named to a member of the staff. Time to remind members and our visitors, if you've got any mobile phones, if you could turn them off or accept silent, please. And also to advise the meeting, all or part of this meeting will be recorded for future broadcast. Move on to apologies.
Got apologies from Councillor Margaret Pomfret, and Councillor Watkins is substituting for her. Also Councillor Elliott and Councillor Caroline Phillips is substituting for her, and I believe that Councillor Brindley may be late chair together with Ingrid Klavitz.
Some members are stuck on traffic. Move on to the minutes of the meeting on the 15th of March. Members happy for me to sign it as a true record?
Yes.
Okay. Declarations of interest. Any member got any declarations of interest that are not covered on in the paperwork already? Any member? Public consultation. This is Michelle Conlon call. After we'll speak after item 6 being presented. Move on to item 6, better health, better care, better value. With the STP, I believe.
Okay, thank you. President, I'm Andy Holly. I'm CEO at University of Country in Warwickshire and also the STP of Country in Warwickshire. A couple of questions to me first. You asked me to do a presentation. How long do you want me to talk for? Obviously, I welcome questions. And also, do you want me to give an overall about where the STPs come from or just get straight into where the work programmes are?
Members' wishes?
I think we know quite a bit of the background sort of from about a year ago, but it's gone quiet for the last year. So if you could sort of bring us up from when the proposals came out, I think it was December 2016.
Yeah, the first published in December 2016. Okay, yeah, sure.
And you can talk for as many hours as you want.
Yeah, we do have
well, make yourselves comfortable then.
We do have a 3-hour rule. Councillor Hancock, you're indicated.
No, I didn't. Sorry, I thought we got a new chairman.
No, I was interested in members' views. So.
Okay, well thanks. Well, as you say, the STP, as it was then known as the Sustainability and Transformation Partnerships, published its initial thoughts, and that's all there really were at that time in December 16, in line with the national timeframes. And lots of things have moved on since then. I think there's been lots of recognition that the process up to that point was not a great one, was not an inclusive one, and didn't enable us to do everything we wanted to do in terms of, you know, if we started this again, how do you do these plans that was led through NHS England? And principle in that was certainly around lack of inclusion engagement with local authorities. Although in Coventry and Warwickshire we had membership of both Coventry City Council and Warwickshire County Council round the table of our STP right from the off. Which was quite unique, but still wasn't enough. Certainly elected members didn't feel party to the plans, and I think that's been the case throughout the country. So what's happened since then? We've had a couple of change in names nationally. So we went from, I think, at that time they were called Sustainability and Transformation Plans, then went to Partnerships. We took a view locally that, and this is reflected quite a few places across the country, that the brand of STP, for some of those reasons I've just mentioned, became quite toxic and was gained lots of negative publicity. And so we thought, actually, what are we about? What are our plans about? And if you think that where STPs were first thought of was in the National 5-Year Forward View, which was published by all of the bodies of the NHS a few years ago now. And that talked about 3 different gaps that the NHS as a whole face, and we certainly face that here in County Warwickshire. Looking at health gaps and the variations in health. And you can measure those in lots of different ways. You can look at variations in mortality and expected life. Within Warwickshire, there's massive variations in country variations. Depending on where you live and where you're born can make a big difference, and that just can't be right in 2018 and moving forward. So there's care variations. There was health variations in terms of access to healthcare, quality of healthcare outcomes, which vary across the country, which vary in Coventry and Warwickshire. And then there was the resource gap, which, of course, at the time of the 5-Year Forward Review, that's what garnered all the public attention. We talked about what was there, a 30 billion gap in the NHS. The NHS said if you give us £8 billion, we'll find 22 billion. And gosh, that we've moved on considerably since then, because the NHS as a whole is much more financial challenged than those figures. And indeed, when our plan was published in December 16, I think all the headlines went to 2 or 3 things, principally around the financial challenges that were identified, and completely incorrect headlines in local media about the fact we were looking to make cuts from health budgets of 270 million. Actually, the figure was 267 million. That's not what the plan said. What the plan said is if we did things in Coventry and Warwickshire in the way we always did, knowing what we knew about expected increase in demand, then expenditure would grow like that against a budget that would grow like that, and the gap between the two would be about 270 million. And one of the key things we should say there is we were also very clear that even before recent announcements by the government, we were going to get more money to spend on healthcare in Coventry and Warwickshire in 2020 than we did in 2015, and that was the 5-year period we were talking about. But we recognised that if we didn't do things differently, we'd be spending £270-ish million more than the budget, the increased budget we had. So we've got to do some things differently. And there's lots of different drivers to why we were looking at that potential gap. It's also worth saying that comparatively to the rest of the NHS, ours was one of the smallest gaps of the 44 STP footprints, by far one of the smallest. But that grabbed all the headlines incorrectly, saying it's about cuts, and it wasn't. It was just about how we live within our budgets better than we would have done if we didn't do things differently. And then you got some bizarre headlines coming out around things like we were shutting various services, we were not going to be operating on anybody who's obese or smoking in the patch. And you can read that report that was submitted and published in December 16 as many times as you want, and you'll never find that in there. It's never even been discussed, some of those things around obesity, smoking, etc. We have talked about obesity and smoking very much so in terms of prevention of healthcare moving forward, but that's where we were. So we took that on board, we listened to lots of people like they were, and it's also important to say that there were no decisions or suggestions around decisions made in that plan that was published in December 16. What it identified was a number of areas where we thought, as health and council senior leaders, that we needed to address challenges, to address those 3 gaps of the care gap, the health gap and the resource gap. So no decision made. And so what we did is we thought, okay, we started to move on towards some of the work programmes, which I'll go through. And we titled ourselves Better Care, Better Health, Better Value, to address those 3 gaps that are identified with the 5-year view, to address the gaps we know we've got in Coventry and Warwickshire. And in some parts, the variation is massive. And I say it's important to remember we do cover Coventry and Warwickshire, and across the two there's some large challenges. We then sort of identified the work programmes, and I can go through those. And there's been some variations in that period of time since you would have seen those. And Andrew's going to talk to us later about stroke. And it's important to say that the work around the need to centralise stroke services across Coventry and Warwickshire precedes the STP, but we brought it under the banner. I know, and Andrew will agree with this one to us later, but some of us are very embarrassed it's taken so long to move where we need to get to on stroke services. And the STP is going to learn lessons from that about how we can do things quicker when it's the right thing to do for patients, which the stroke centralisation absolutely is. So some of the work programmes we're looking at, I mentioned prevention. We want to upscale prevention. It's great having John here as an expert on this, and working closely with all our public health colleagues with Coventry and I talked about things like obesity, things like smoking. We have some high smoking rates still within this patch. Within Nuneaton and North Warwickshire, we have some very high levels of obesity, and the connection to ill health and ongoing ill health challenges of obesity and smoking are unquestionable. So what can we do about those things? We've heard announcements as recently as today around looking to ban the sale of high sugar content goods within hospitals. Absolutely right. So there's a whole work stream around prevention. There's a whole work stream around plan care, and this comes towards some of those variations of access to care. And why is it that you can get access to certain levels of care in the south of the county, which may be or may not different to the north of the county or to Rugby or to Coventry, and somewhere and it goes both ways. So we're looking at that. We have a massive challenge in Coventry and Warwickshire around urgent emergency care, which is our third work stream. Anybody who reads the press, listens to the TV or the radio knows that the challenges we've just had, we're still in winter in many ways in terms of the winter pressures on the NHS, are unprecedented. So we have seen numbers of people turn up at our emergency departments across Coventry and Warwickshire in the last few weeks than much more than we've ever seen before. So the question around this work stream was, what is the whole offering about urgent emergency care to our populations, not just about ED, emergency departments or A&E? Because that's what gets all the attention, but actually there's so much more we can be doing people who have care needs on an urgent emergency basis, who doesn't actually really need to go to the emergency department. So what can we do about those? So there's a whole work stream about that. We have a work stream around maternity and paediatrics, and certainly that's the classic one around completely made up headlines that go back to December 16 around there have been decisions made to close paediatric or maternity units across the patch. No such decisions have been made, no such decisions have even been talked about, and that still remains the case today. What we do know though is that we have got challenges. Where there's a national shortage of paediatric trained both medics, doctors and nurses. So why would Coventry and Warwickshire be any different to that? So what is the way forward? When we talk about financial challenges facing lots of different NHS organisations, particularly acute hospitals, like my own, the two I run at Coventry and Rugby and Georgia, many of those financial challenges are driven by workforce challenges. So if you can't appoint staff, or on a substantive basis, you end up bringing in locum agency staff and they cost you more. So quite often, financial challenges are actually a symptom of other issues, and generally those other issues are workforce issues. So we know that we haven't got enough trained paediatricians and paediatric nurses in the whole of the country. So what does that mean for Coventry and Warwickshire, and what should the services look like going forward to ensure that everybody gets the best care they possibly can locally where appropriate? So that's what that work stream we'll be looking at as it moves forward. A whole work stream on mental health and emotional well-being. I absolutely say this as an acute hospital chief executive. Mental health has been overlooked, hasn't had enough focus on it for many years in the NHS, and that then results in lots of challenges. Within the Combined Authority of the West Midlands, obviously, which Coventry and Warwickshire are now part of, there's been a lot of work looking at this, the effects of mental health on the economy. But I also see, going back to my emergency department, I can tell you that at any one day, and so this was the case this morning, I've got 10 beds in my observation wards taken up by people with mental health issues who would be better served elsewhere. So what do we do about it? And the effects of mental health on healthcare are staggering. There was then a work stream on productivity and efficiency, and yes, this was absolutely looking at things like back office functions. Can we do things more efficiently, like you've done? I know you share local authority services with Rugby, etc. So can we do more of that in the health service? But also looking at where we have duplications of care sometimes, which are unnecessary. So a classic example of that may be in where we look at patients who need to be discharged. How many different people make an assessment of what their needs are? Do we have an occupational therapist do it? Do we have a physiotherapist do it? Do we have a social worker do it? Do we have somebody from our react teams? but actually we should be having one assessment. So to get rid of those duplications in clinical areas as well. And so they were the work streams, and things are starting to move on. Each of those work streams has a designated executive lead, so a chief executive or equivalent from each of the different constituent bodies within the STP. So prevention is led by Gail Quinton. Gail Quinton is Deputy Chief Executive and Director of People from Coventry City Council. Early emergency care is led by Glenn Burley, who is Chief Executive Officer of the South Warwickshire Foundation Trust. Maternity and Paediatrics is being led by Simon Gilby, who is Chief Executive of the Coventry Warwickshire Partnership Trust. Mental Health and Emotional Wellbeing is led by Sharon Binion, who's Medical Director for the Partnership Trust. And Productivity and Efficiency is being led by Kim Lee, who is Chief Finance Officer of South Warwickshire FT. The pace at which some of these work streams go on is all different. We are nowhere near where I'd like us to be in terms of where we've got to. We've certainly, as I say, we've made no significant decisions, but we won't make any decisions that have any significance to the population we serve without going through full engagement and consultation where appropriate and where required. Andrea, it's great that Andrea's here, is the lead for engagement and consultation for the STP where that's required, and indeed with that hat on is why Andrea's here for Anne Stroke today. We are also looking at other work streams though, and to enable us to move things forward. So for example, the estates. There are an incredible amount of properties and estates owned by the NHS in Coventry and Warwickshire, and we're absolutely sure that if we think about our productivity agenda, we don't need all the properties we've got. You know, we're talking about 200, mainly in mental health and community. Do we use our hospital sites as effectively as we can? And I know you would have all seen some fantastic stuff that George Elliott have done about looking about how they can use their space, because they've got a lot of space on their site. How do we utilise that better, put more things on there? And that's what the kind of things we're looking at in terms of health campuses. And that's the future of hospitals. Not just thinking about the acute services they provide, but what's on their service, what do we wrap around those hospitals. We are looking at digital transformation. Without a doubt, the NHS is a long way behind some of our like-for-like systems. If you look at America in its utilisation of digital technology, and that can bring around transformation, which brings better healthcare for our patients, but also then becomes more efficient. So they're the work streams. We have suffered, I think, as an STP, like I said already, that by the suspicion around STPs that decisions were being made in secret, that it was being driven by the health service. That bit is true, it is being driven by the health service. It's very much being driven by NHS England, and that's where they came from, 5-year plug. We'll accept that. But this is, we tried to say very early on around our board table, we had not just the representatives of the health bodies, statutory health bodies in Coventry and Warwickshire, we had representatives of both Coventry and Warwickshire councils, as I mentioned, and also both health watches in Warwickshire and Coventry. No decisions have been made around any significant service changes. We haven't identified any significant service changes that need to be made yet. There may well be some, there may not in different areas. But it would be, I think, foolish, or we'd be kidding ourselves that the pressures that are faced by the NHS as a whole were immune from those in Coventry and Warwickshire. So the key to this is how we do that in a planned way, and whenever we look that we might have to make some difficult decisions, we'll be doing that via full engagement and consultation. So that's where we are really. I hope that makes sense. If there's anything you want to explain more, then just say. If there's any questions, just fire away.
Plenty of questions. I've got a speaker first. Mrs. Condico.
Well, I followed this quite sort of significantly as it's progressed, and Andrea knows I've been to a lot of the CCG meetings and asked questions and what have you as well. I'm just concerned really as to, it seemed very compartmentalised, and Coventry and Warwickshire isn't sort of a definite, I mean it is a definite area, but for example George Elliott takes a lot of patients from Hinckley and Bosworth and things, and how do these, is this all sort of, it needs to be more integration and things, and I just can't believe also that there's been no public consultation on anything.
We haven't got any options to consult on, frankly.
Yeah.
What I will say around Coventry and Warwickshire as a defined health patch was actually, if we go back to when STPs were first thought of, Coventry and Warwickshire was one of the easiest patches in the country to identify. And the reasons for that is that there's been a lot of close working across Coventry and Warwickshire, the old Arden beforehand, when we had PCTs, etc. But more importantly, what's quite unique about Coventry and Warwickshire is that over 95% of our healthcare needs are provided within Coventry and Warwickshire. So, and one of the reasons that is obviously with the University Hospital, we have a specialist tertiary services for specialist services, whether that be cancer, neurosurgery, cardiac surgery, etc. And the only care that is needed to be provided in secondary or tertiary providers outside of Coventry and Warwickshire is really for two reasons. It's the very, very specialist work that we don't do at University Hospital, so that may be some, for example, heart transplants, which are going to Birmingham or London. Or if they're very south of the county, there is a natural flow of work into Banbury and Oxford, because actually geographically that's nearer to those populations than either Warwick Hospital or our hospital is in my hospital country. So actually as a patch, it was one of the easiest to define and say that was the right footprint. And what we're seeing across the country is, as I said, there's 44 STPs, we're already seeing some of those changing, and they're changing because some of them aren't large enough for sustainable services. As we move towards, you've mentioned integration. I mean, the buzzwords at the moment in the health service is around integrated care systems. Because we know that to get some of those efficiencies and effective healthcare, we need to think about integrating services, but they're much smoother. I talked around where we duplicate things. You know, there's too many touch points between community services, acute hospitals, social care, where we've got things going on we don't need going on, then it's not smooth enough, and the patients suffer and actually cost more. So there's a lot of integration going on. This is very much about integration. Yes, there are some flows into the Elliot from Southwest Leicestershire particularly. There's at least as many flows into South Warwickshire Foundation Trust from Solihull and from Worcestershire, if we think about the Reddish, Studley border. And of course, at University of Coventry, there's much more people coming in there from Worcestershire, Leicestershire, and further afield, Northamptonshire, for specialist services. So we do get there. So they're not all about everything's within that. There are flows across all of them. Integration, you mentioned, I say, is particularly relevant. We say we do too much duplication for our patients. And so we've got to get better at that. I will say absolutely in front and put on record, that does not necessarily mean we have to merge organisations. It's not about merging organisations. It's about how you get better pathways of care. For long, the incentives and the way that the health service has been funded has led to people thinking in silos. So as an acute chief executive, I think about the patients that my organisations need to treat and how I get funded for that. Community chief executive will say exactly the same in their organisation, and mental health will say the same in there, and social care over there. This is about how do we get rid of some of those disincentives close to working to make us work better. And one of the things we're talking about is having, for example, a joint combined control total of finance. So I could be, Andrew, I don't understand this, I could be accused as a chief executive accused, if I keep driving activity, I get paid for it, I sort my own financial problem out, it might leave a financial problem in the commissioning staff to pay for all that. What's the point of that? So actually, if we have a combined control total, it says that the money that comes in to Coventry Warwick, which is about £1.3 billion for health, none of us are successful unless we're all successful. So what's the point of me having a surplus and a deficit with my commissioner? Or a deficit in Trust X when there's a surplus in Trust Y? So we want to move away from that. And how can we best spend that one, every pound of that 1.3 billion most effectively for the patients we serve? And that's got to come via integration and get rid of some of the crazy funding mechanisms we've got. And we have the local autonomy to do that now, which we didn't have before STPs.
Sorry.
Yeah, Mrs. Godcourt, you've finished.
I suspect so, yeah. Anyway, I'll think of 101 things in November.
So, thank you for that. Has any member got any clarifications on what Mrs. Godcourt said? Move over to members now.
Okay.
So to debate for members. Any member? Councillor Phillips.
Thank you. I've just made a few notes that I'll just go through if that's okay. First of all, do we have an end date for when this has to be achieved?
Okay, when the plans were first put in place, they were 5-year plans to reflect and mirror the 5-year forward view of the NHS portfolio. And so when we talk about that was these things were the 267 million gap, that was at the point of 2020-21. So the start point was 2015, although they weren't published for 2016, which is always a bit of an anomaly, actually. What we're very clear is, and of course the funding regime of the NHS has changed, it is going to be changing, there's an expectation of more money coming to the NHS. Whether or not it does, we've still got these challenges around health and health variations. So whilst the initial plans had that 5-year spectrum, we're actually already 2.5 years into that. The conversations we have around the board table of the STP are fixed on 2020. We're thinking there are things we will do in that time scale, but some things are going to take longer. And actually this is about how we best provide and commission health and social care for the next 10 years or 15 years. We know the NHS is its 70th birthday this year. We should be thinking about what the NHS looks like in 10 years' time, not in 2 years' time, because some changes you can't make in that period. So they're the conversation we're having. So yeah, officially the answer is 2021, but we're looking beyond that.
So I haven't heard you say much about social care.
Okay. Sorry if I missed that out. Social care is integral to this. I did say both the councils are representative of social care commissions and providers, so i.e. Coventry and Warwickshire. The financial gaps that I've just talked about did not include social care. So, and I think there's two things I should point out on that. One, when we looked at we asked both of those councils what they thought their challenges were. They both stated that they could cover their own challenges in terms of social care budget issues. And we know that social care budgets have been decimated, frankly, I can say that, over the last 3 to 4 years. And we've seen particular challenges in Coventry.
4.6 billion.
Yep.
That's
Yeah.
how much they put.
We've seen 45% cuts on average between Coventry and Warwickshire in the last 4 years for adult social care. The challenge has been greater in Coventry because they've needed to invest in children social services following the Daniel Pelker case. So that's heightened the challenge on adult social care in Coventry. What of course to say, so when I say there's two parts to the challenge, financial challenge around social care, is that whilst both councils said they could subsume their own challenges over that 5-year period, what that does not take effect of is the knock-on consequences that are faced in healthcare services due to the cuts that have taken place and are due to take further place over the next coming years. And so that is measured, that will be in tens of millions of pounds. So, I started off with, we know there's lots of pressure in the health service over this winter. Some of that pressure has come about because we've seen lots of nursing homes, care homes, etc. closed in the last few years, so there's nowhere for patients to go. Your hospital gets clogged up. That's measured by not getting people through your A&E department. So there's lots of challenge around that. What we haven't talked about is the potential for integration of health and social care across Coventry and Warwickshire with what's within our own gift. Obviously, there's nationally, we now have a Department of Health and Social Care. So that does, I think, give us a way forward about what the government sees as the way forward for health and social care. And actually, if we go back to previous administration under a Labour government, they were saying exactly the same under Andy Burnham. But locally, we haven't made any of those decisions, we haven't had those discussions. What we are very clear on, though, is that there is too much duplication, as I've already mentioned, and not enough, for example, information shared between the two that could make services more effective for our patients, because they are the same patients. So we are having those conversations, even if I didn't talk about it as much as I could.
Can I add something there, Councillor Phelps? Nigel Mims, who's Director of People at Warwickshire County Council, was originally invited, so I'm here, if you like, representing him. He's on leave. I think the issues you raise about social care are very important, because I think we need to see, and Andy has referenced this, the health and social care as a one system. And the finances obviously are a significant issue, though there has been additional money, as you will know, with the council tax precept. But it struck me, and I had just happened to cut this out today from my reading, because Jeremy Hunt about 10 days ago was setting out, Secretary of State was setting out to the Association of Social Workers some of the principles he sees as guiding the future of the NHS and social care. And I won't go through them all, but he mentions whole person integrated care with the NHS and social care systems as one. And I think that's something that we're actively looking at. How do we ensure that we provide services wrapped around the patient and the needs of the patient or the client, rather than depending on the existing organisational structures we have.
I totally agree with that. Many of you know that Jeremy Hunt visited both George Eliot about 2 months ago and also my hospital 3 or 4 weeks ago. And in my conversations with him, he asked me so many questions, and I've said this before STP came along. If you said to me there's £10 million extra you could spend in Coventry and Warwickshire, I wouldn't put it into my own hospital or to the acute units. I'd put it into social care, community care, and mental health care, because that's where it's needed. And actually, some of the challenges I face as an acute chief exec would be helped sorted by that investment going into those services, not into my own, because they're the services that have suffered over recent years. And that goes now. And I know that actually, Jeremy will tell you that he fought to stay in his job, number one, but two, actually was to bring social care together, because it's got to be the right thing. And to be fair, I say Andy Burnham was the person who really pushed this under his agenda as health secretary.
He was talking about this a decade
Yeah, he was,
ago.
And nobody's done anything about it. And I think I agree that it's the thing to do. And so we'll do what we can do within the boundaries of authority we've got at the moment. But I say that doesn't mean organisational mergers, it just means actually thinking and working as one organisation. Yeah, you've got some funding challenges around the difference between VAT being applied or not, but we can work around those.
What about cuts to the public health budget? That's had a 200 million cut. How does that fit in with tackling obesity and things like that?
John definitely is the expert on this one, but I'll tell you from as an economist and accountant, I can tell you what I think about that. Of course, well, first I think the decision to move public health back into local authority was the right one, because we know that most determinants of health are actually not what the health service does, it's what other things do. We've got a job, are they good housing, etc., etc. Those budgets were ring-fenced. Was that till this March or last March?
It's been extended for 2 years.
And so the budgets are ring-fenced within those tier 1 authorities that host public health, and I think that's right. As for those figures you've just identified in terms of cuts, I don't recognise those. That doesn't mean I'm questioning them. I just
From the
don't
King's
recognise them.
Fund.
Oh, okay, John, I mean you might be able to answer that one better.
Yeah, well, George Osborne imposed a 200 million cut
Okay.
2 years ago.
Right. Okay, I wasn't.
But your point, I mean, I think that is a significant challenge, and wearing my Director of Public Health hat, one of the things I'd like to see is within this system of health, NHS and social care and public health, that the whole system takes on responsibility for delivering public health. Because it's not just about resources, it's about the interaction with the client or the patient. And can you imagine if we had every time you went to outpatients, as well as, you know, checking your weight, and they also asked you, did you smoke, and checked and said, look, if you're interested, we can help you. Now, sometimes that happens, but it doesn't happen as consistently as it could. So there are lots of things we could do together.
I think the other thing is, we are all major employers as well. So I think my organisation, we employ 10,000 people, including bank staff, so 8,700 plus some bank staff. So we're one of the 3 largest employers in both Coventry and Warwickshire. Other public sector are the largest employers as well. What do we do for our staff to encourage them to eat healthily, to get chances to exercise, to have access to smoking cessation if necessary? And so we all as employers need to think about that as well, and take a lead from public health, but we shouldn't leave everything to public health as employers. So in my organisation, we do things like having outdoor gyms, wellness, well-being sessions, etc. What can we all do?
Thank you.
Thank you, Chair, and thank you for coming to speak to us today. It's been a long time coming, so I'm pleased that you're here. It is a shame that Councillor Seckham isn't here, because I'm glad that you acknowledge that there were potentially some failures early on in relation to communication and the development of this. And, you know, I feel that falls at the door of political decisions. However, I'm glad that you recognise that, and going forward I hope that we'll learn lessons. In relation to another process question. When the names that you mentioned who are leading on areas of development, a lot of those names appeared to be from the south. I didn't pick up any names of anybody who was senior within the north.
Okay, that actually, in terms of stream leads, that's correct, except Andrea is leading the engagement and consultation.
I've now got planned care.
And
just taken
okay,
over,
there you go.
so
That's one I missed out, because I knew we were about to, in discussion, and giving feedback to me. So there you go. Plan care. I say in commentary, so there's, say we've got Gail from the council. I don't want people to think that there's any significance of that, where they're coming from, because one of the clear things is, so I've been very clear with when everybody comes in the room, they drop their organisational identity. We're here for the people who come to Warwickshire. So actually, maternity and paediatrics work stream was being led by Professor Megan Apandi, who's my Deputy Chief Medical Officer until recently. So now Simon's taken over as Country and Warwickshire Party Trust because they're across the whole of Country and Warwickshire.
I think what's important is that I want to be confident, as a representative of the community and all of us here today, that the voices of people here in Nuneaton and Bedworth are heard, and across North Warwickshire are heard when you're making decisions and developing your policy direction. Because the important thing is that in Nuneaton and Bedworth, not only do we have more people, but we have more need, and that's often not recognised or fully met. So
the only thing I'll disagree with that, if I may, is we have a different need in North Warwickshire. So the south has more elderly people as a proportion of their population, so that brings healthcare challenges. Coventry has one of the youngest populations in England, so that brings different challenges with it, as does its migrant population. And North Warwickshire, with its, both in terms of Nuneaton and Bedworth, and also importantly the rural areas of North Warwickshire have very different healthcare needs too, from our mining industry, etc. So I can absolutely guarantee you that all voices are being heard. The North is very well represented in terms of a voice, both in terms of Andrea with her role as Warwickshire North CCG leadership. Kath, on behalf of George Elliott, also obviously spends a lot of time talking to local populations. And for what it's worth, I'm born and bred in Nuneaton, so I do that as well.
So obviously, while I would I don't disagree that everybody has needs, but I think that we have not only a set of different needs, but actually a more intense needs. So we have deprivation, we have people who die earlier, our mortality rates are lower, and there are lots of factors. But I think the question from that is, will you be undertaking, when you develop this, an equality and diversity impact assessment to properly evaluate the impact?
Any kind of decision would include that.
Yes.
We wouldn't be able to make decisions without it.
And also in relation to, while your point in respect of stroke services or centralising services has possibly better patient outcomes, and we all want that. We want people to have specialised care and better care. My concern, though, is about their family members and loved ones and friends on accessing hospitals or seeing their loved ones. And obviously, if you're in Nuneaton and you want to get to Coventry or even Warwick and Leamington, it's incredibly hard and incredibly expensive. So, I mean, will you be considering that kind of impact on local people?
Yeah, I can guarantee that. And indeed, when it comes to about stroke services, that has been considered.
Go through what we've done and some of the actions we've got in place to try and address some of those inequalities that may come through.
Right, picking up on the last point just made first, we really need a half-hourly bus service into the Walsgrave because so many people get caught out by the services that are on offer, and it's so congested at your hospital. To sort out the transport is an absolute must. And for just a check-up, I actually dropped my wife a couple of miles from the hospital, and she cycled the last couple of miles because if you're going in the morning, it's actually nuts wasting so much time and wasting someone else's time to try and land someone in there. So transport is absolute key.
Just on that, if I can make a plea. As an organisation, and which I'll go back to my chief executive role now, we're about to put a planning application into Coventry City Council for additional 1,600 spaces, car park, which will be an absolute game changer for our patients. So please support it.
Well, I'd like to remind him that probably some areas of town, a third of the people do not even have a car between the
I know, I get that,
So
but it tends to be will help a number of people.
it tends to actually, and also a lot of people are going in for eyes or whatever, and they can't drive when they're going in hospital. A lot of people have to go and take people to the Walsgrave and the Nuneaton and Bedworth, and it is something that you really need to get a game. And don't think all the people making decisions have got cars, they're all healthy, and the people who are coming in necessarily.
I don't assume that, but just as you brought that up, I thought I'd mention it as well. In terms of the bus service, I think you make an incredibly valid point. We have basically a bus coming off our site every 2.5 minutes during the working day. But that doesn't mean that North Warwickshire isn't well suited. You'd have to get a bus into the Nuneaton and then out. And some do go direct and some don't. And so I think that is a conversation we jointly, local authorities and health services, should be having with our transport providers. So,
in terms of the STP, there are so many organisations in need of money. We've got so many planning applications coming through, and every little bit of the NHS is fighting for a little bit of money from the new developments, etc., rather than there being a person grabbing money from developers for the expanding population. And you talk about students, older people, the population is growing and the people are getting older, and we waste so much money and lose so much opportunity through the planning system, and particularly things like mental health. They're not even asking for money from the planners, whereas if we had a more joined up system of actually funding increased capacity from the planning system, it would actually make a lot of sense and would actually get money for the whole system rather than the bits that are actually most aggressive. I know the George Elliott's suddenly woke up and being a bit aggressive at the moment, getting planning funding, but then you've got the GPs, you've got the mental health. The whole system of planning and funding NHS is disjointed.
Agreed. Sorry.
I was just going to say, actually, for that reason, one of the enabling work streams in the STP has been the estates strategy and looking at the planning of estate across the patch.
Yeah, and just on that, in terms of accessing money from developers to go into health services, particularly as we see massive house growth, house building growth across the country in Warwickshire. There's some big numbers when we look at those. You know, if you think about rugby, for example, some massive house numbers going. Ironically, locally, South Warwickshire Foundation Trust have just not long ago won a test case nationally, which will mean the accessing of that money and getting the money from developers will now be easier. And actually, lots of people from all over the country are coming to see what Warwick have done. So obviously they're in our patch and we'll do that as well. We do that in Coventry. You're right, George Eliot now starting to think about that. But it's not just the George Eliot and the secondary care providers, it's mental health and community. Because actually, when you get a house building, the major area of challenge to the health service actually is in primary care, having the right GPs in the right place, but not just for GPs or the primary care services. So we do need to do about that.
And then if I may, Chair, there's a lot of issues about transparency on the whole process. And if you've got leaders of Warwickshire County Council, Coventry City Council, people in Nuneaton and Bedworth have just got no visibility of what's going on. The STP process doesn't seem to produce lots of minutes about their meetings or their progress. It is very, very hard if you're not the leader of Warwickshire County Council or someone big in Coventry to know what's going on. And we need to improve the transparency. I follow Michael Paduano on the Twitter and things, and the issues that people
are against that, but that's just a personal
but just a general issue about seeing what's going on, having it reported. You complained at the beginning about how rocky the process has been, but actually if you're more open, and actually particularly from the Nuneaton and Bedworth, which is poorly represented in these streams, we need to see what's going on. And actually it's better to take the hit of actually people making a fuss when they find out about something than actually them not finding out for 9 months.
I totally agree, and it goes back to what I said, but the process that was set up, if we go back in history, by NHS England, when STPs first came about, really you would never do it like that again if you had the chance. So if you think, they were only ever talked about the first time in about November 15. We get through to about February, March 16, and health service leaders saying, what should your STP patches look like? I say, as one of the easiest to define. We're then given this ridiculous timescale of the end of May to have the plans together to meet those 3 gaps I've talked about. And so you just go and do what you can, and that all it ever could be was identify work streams. That was then extended to August. So at that point, I was if you said in February you got to August, you've done it differently. Then it was extended to October 21st, was when they were submitted, October 21st, 16. So you actually had an 8-month period. If you just said at the beginning of that 8-month period, right, this is what you're looking to do, we'd have done it a much different way, and there'd been much more people would have been involved in that. So the process was a really poorly designed one. And I say it's put a long way off on the back foot ever since. What I can absolutely guarantee is, though, as is already, there will be no decisions or even options from which decisions will be made generated without full engagement and appropriate engagement where that's needed. And I hear the questions, firstly the challenge, which is an appropriate challenge around the differing health needs across country, Warwickshire, North Warwickshire, etc., and the different voices. But I will say, the voice from North Warwickshire is as strong as anywhere else.
And just one final point for me, Chair. The life expectancy thing, I'm really angry that people say we've got more needs in the south because they live longer when they're older. We have an issue with actually saving the NHS money by dying in this town 10 years earlier than some of the other places.
And if you go to Coventry, they die even earlier.
But we need to actually look at that problem
Yeah.
and actually really try and change the environment so that people live as long in Nuneaton and Bedworth as they do in Stratford.
I totally agree.
And a key part of that is looking at the factors, the air pollution, the industrial heritage, the diet, and the lack of GPs. I mean, we need to transform our NHS.
Yeah.
And one of the troubles is, if you want to be a GP, you want to be a GP somewhere where the population is healthiest.
And that's because there's a national shortage. And one thing we have got to do is when we talk about primary care, is think much more than just GPs. GPs are incredibly important, they lead that, but it's the whole of the service. And the variation you talk about it is massive around expected life expectancy. It's actually even starker if you go to Coventry. We often talk about the number 10 bus in Coventry, which goes from one side of the city to another. If you're a male born at one end of that bus route, your life expectancy is 10 years less than it is at the other end. It's just, it's almost unbelievable in 2018, but that's what we're facing. It's stark in north versus south. When I mentioned the south, what I meant is that people are living longer lives in the south, which we need to equate. But it's about the quality of that life and the healthcare. We know that as people get older, we have more comorbidities, different things that are wrong with us, 2, 3, 4 different things, and that need treating. So that's where the challenges come in, greater dementia, etc. But fundamentally, in Borough, people who are born and live within North Warwickshire live shorter lives than those in the south, and we can't let that carry on.
Yeah, thanks, Chair. Well, Chair, within the NHS, the one consistent thing there is change. It changes all the time within the National Health Service, and it doesn't really help the whole process. Having said all that, we have to recognise the fantastic work that people do within the NHS, and I think generally that's recognised. There are criticisms made, but generally I think people, when they need the service, they get that service. The unfortunate thing with that is some of the waiting lists are getting longer. Things that are important to people, like hip replacements and things, they're the bits that are now being prioritised at a lower level than other things. And I can understand that because of the budgetary pressures and things like that. But I think it's worth repeating what Councillor Margrave said, because it's an old chestnut of mine is, if you're actually if you're the patient or patient-to-be, you probably don't mind too much where you go to get that care, because you need that care. But equally important to that surgical care or whatever it might be is the support of your family and friends. And if that's made difficult by accessing things to stop people visiting, that will also delay your departure of your patient, which leads on to that bed blocking thing. And anything that you can do to prevent people going into hospital needlessly, I know I'm going off on a bit of a tangent, but anything that you can do to prevent that is helpful. So you've got the social care sides of things. We used to have what they called care in the community, and it was a great idea, but it didn't work because the support wasn't there for it. So you had lots of people, particularly with mental health issues, that were left pretty much abandoned within the community because there weren't the people to check that they were taking the medication at the right times and things like that. The idea of it, the principle of it, was good. The other thing that I feel has dropped away over recent years as well is health promotion. And I remember there was quite a lot of money put into it some years ago in relation to AIDS awareness, and it had a tremendous impact on that. And you know, the figures came down dramatically, but it all fell away, and then they started coming up again. And I just use that as an example because it relates to other areas of health promotion as well. And the reason I say that is, again, that type of thing helps to prevent people going into A&E in the first place, and then you know you're not blocking up those beds. But as already been said, we represent an area within the county, Nuneaton and Bedworth, with very poor health outcomes. And while we recognise the larger picture over country and Warwickshire, we've got an area that's in need. My own ward is recognised as a major area of deprivation, as in many others. And my ward is actually similar to the number 10 route in Coventry, in as much as I've got one side of it is pretty affluent, got the town centre, and then you get onto the other side, which isn't. And you know, I often go to residents' meetings in one area, and you know, it's only a mile and a half apart, and they don't actually recognise the needs of that other section of the community. A couple of questions, if I can, Chair, because Andy mentioned about decisions and full consultation. Can I ask, will those consultations be taken before decisions?
Yeah, absolutely. Yeah, it's not consultation otherwise. Yeah. Well, and I will accept that the health service and public sector as a whole over the years has been littered with things called consultation, which clearly weren't a consultation.
No, and that's. I thank you for that, because that's exactly the point I'm making. Historically, within the NHS, I guess overall, but particularly local, it's been a case of a decision being made and then the consultation process coming afterwards, and it's the wrong way round. So I'm pleased about that. And just one other thing on a parochial sort of basis, and it was mentioned right at the start of your presentation, Andy, is you did say there's been no discussions or decision on closing or removing maternity or paediatric services. And I want to be absolutely certain on that there's no plans to either close or relocate the services, because there's a difference in the wording. You know, you can say we are not removing services, but you could be shifting them to somewhere else.
Yes, I can't. Yeah.
And
well,
so
what I can say is there's been no conversation about relocation either. Then. I think you make a really fair point. Can I guarantee that will be the case in 5 or 10 years' time? No, I can't. Of course, I can't. I'd be daft to sit here and say that. But there's been no such conversations about closure or relocation, if that clarifies.
Okay, thank you.
Any other member? Councillor Walton?
Yeah. Just a few points really. Fairly newcomer to being a councillor, I've been here 8 years now. But even so, going back to when I went over to county to have a meeting over there, and I brought up the fact that NHS England underfunded us in the south. Yeah, that's historical, councillor, that was the answer I got. So when you said that it's driven by NHS England, and you was quite pleased about that, well, I'm not.
No, I wasn't pleased about it, I just said I accepted it, so I'm pleased about it.
Well, I'm not pleased about it, because they think it's historical that we're underfunded in Nuneaton and Bedworth, and that's fine. I know, so I'll just make a few points, you can answer them as and when you want. You went on about some shortages that we've got. I think it was last year sometime, we heard about the George Eliot going to the Philippines to get some nurses because they couldn't get them in Britain.
Yeah.
I don't think that was very successful, so we already know that there's a shortage on nurses, but still we're sitting here again today, we've still got a shortage on nurses. public health going into the local authority, meaning local authority as in county.
Yeah, sorry.
Yeah, but
Local government is what you said.
yeah, well, it's not always good again for us in Nuneaton and Bedworth, because although we bring a lot of things up with county, it doesn't mean we get listened to. We brought up at the last health meeting about the JSNA not getting listened to at county and not getting taken seriously in the developments. And it's the developments that are causing a lot of issues within Nuneaton and Bedworth. You also went on about obesity and smoking, but didn't hear anything said about heart diseases and cancer, which is another big killer within Nuneaton and Bedworth.
Yeah, but I suppose my point would be that obesity and smoking
Would lead to that, maybe, yeah.
Lead to terms of those issues.
Not necessarily.
The biggest ones.
And then you said things about the hospital or whoever doing things to get people active. Well, we was probably some of the first people to get some green gyms around.
Yeah.
We've done the marked miles, we've done fun runs, we've even offered the flu jabs at the council, and we do health checks as well. So, although you offer all these things, doesn't mean
Oh, you can't
does it?
lead the horse to water.
I think when last time we offered the flu jab at the town hall and the depot, I think it was 9 took it up. So.
And just on that point, yeah, that's reflected in some healthcare facilities as well. So we all just had to submit our flu jab rates for all our NHS hospitals.
And the last one really would be on all the working streams. When are we going to actually see any of that come in?
Right, a number of points, and I'll see if I can remember them all. Obviously, the first one's around funding. Then I think you talked about nursing. Then the public health issue.
Yep.
Then around access locally, and then finally. What was the last point?
When are we going to start?
Okay, right, so let's be on healthcare funding. Yeah, there's a national allocation based on the populations we serve, and we have what's called a fair shares. You have a target funding based on the total NHS funding. Warwickshire North and Coventry are still slightly below what would be considered to be their fair share, although we're a lot closer to it now than they've ever been before. And the way that the NHS differentially funds when additional funds come out is those who are below target get proportionally more. So over time we'll get there, and we are closing that gap nationally. So yes, Coventry and North Warwickshire are considered to still be slightly under target for their fair share based on what the total pot is. So that is the case, absolutely true.
But just coming back on that, that has been, like I say, I'm fairly new, come at 8 years, and it's been going for at least 8 years. Or
and well, I can tell the rest. So if I go back to 1994, I worked for Warwickshire Health Authority as an accountant, then I was newly qualified, and the variation was massive then compared to what it is now. So it's gone back 30 years actually. But it has been addressed, and the gaps are much more closer. And the way it was going, you get to a point in 3 to 5 years' time where everybody's more or less on target. And there's good variation here. And then because they do tweak the formula occasionally. So it's now less, I would say, this is my view, less responsive to rurality, but more responsive to ethnicity. So those little tweaks are made each year. In terms of nursing and staff shortages for the NHS, yeah, we've got massive staff shortages in certain specialties. I mentioned particularly paediatrics, didn't I? And that's true for both nurses and doctors. If we look at acute and emergency physicians, massive gap nationally. If we look at geriatricians, massive gap nationally. The biggest gap, though, is newly qualified Band 5 nurses. So I'll give you figures from my organisation. We have 19% vacancies at Band 5, so 1 in 5 vacancies. I have 1,000 vacancies in my organisation, the majority of those nursing. What's interesting on nursing is there's obviously been considerable change the way nurses are funded in terms of their studies over the last 3 or 4 years, in that the bursary has been taken away recently. So nurses were paid rather than to pay fees. That's changed. But in talking to our local nurse training provider, which is Coventry University, they're actually expanding their numbers of nurse trainees. It takes 3 years to train a nurse, but they're seeing this as an opportunity. So whilst applicants to their courses have slightly gone down, they're still getting 20 applicants for every place. So we're seeing that, we're looking at it as a local solution to nursing challenge. And whilst it take 2 or 3 years, we do that. The other thing is, because the challenge around health care workforce planning is it takes so very, very long. So if we said today we need X more paediatricians, use that example, well then we've put things in place, but it's 10 years time before they're qualified as consultants. So one of the challenges we've got to take on, and one of the supporting work streams I didn't mention is a workforce work stream, is just looking at how we do things differently with professionals in healthcare. We know that nurses can do things that only doctors could do 10 years ago. We know that we look at advanced nurse practitioners and we use those in emergency departments. We think about physician associates, what can they do to help consultants and their doctoral teams. So we don't always think that only this can do that until we get to that level you can do this. So we're changing the way we think about workforce whilst keeping skills up. But I go back to, I think in terms of sustainability of health services, I'll repeat what I said earlier, that's the biggest challenge, and one we're not immune. In terms of the work streams, I don't feel qualified to talk about public health when John's sitting here, if I'm honest with you. So in terms of the work streams, as and when we have developments like we've got with stroke, we would welcome the opportunity to come back to these forums. And picking up the earlier point that's made by a couple of councillors around you haven't felt as involved as you could be. You know, if you want me to come back, you just say when really.
I think I did. The other thing we've done locally, and I know certainly a couple of councillors will be aware of it, is the People's Commission in this area to try and do a bit more sharing of the STP thinking and planning. So we've done 2 sessions so far. We're struggling to get people along, I must admit, so we need to maybe have a rethink. But there we've talked about the stroke work that we've done, we've talked about the mental health work stream is the one that we're doing, and I think it's this week actually, tomorrow afternoon. So
young people's mental health.
Yeah, so I'm hoping we'll get some more folks coming along to that one. And we did talk about where we were up to and the thinking on maternity and paediatrics and thinking about children's and young people's health there. So what we're trying to do is use that event to then say, so what would you like to hear about next? So we'll certainly make sure that local council colleagues have got that date so everybody's aware if that's going to be helpful, because that was meant to be more of a discursive discussion about the planning topic by topic. So engagement and discussion rather than the detail in terms of consultation. So as we're building it up, so that should help as well.
Can I add, or in terms of public health, I'm disappointed with what you say about public health because I don't recognise anything that you've said. Over the last 10 years, I have consistently highlighted the issues of deprivation in the north of the county, as well as in other parts. There are other parts as well, but the fact, and there is nothing worse, in my mind, to being in a deprived part surrounded by affluence, because you can get lost very easily. So I've made it a point of my work to highlight this. In terms of the funding, we have identified some significant additional resources for public health issues in the north of the county, some of which have proved very successful, though I agree fully with you that you can't just rest on your laurels, you have to keep doing it. So, for example, we've seen a 50% reduction in the number of mums in the north of the county who are smoking throughout their pregnancy. Now that will have significant implications for those children as they grow up because of that change that has happened. In terms of the JSNA, I'd be very happy to send a briefing to members or to the committee. We have been very open and have invited all of the districts and boroughs to lead the JSNA process in their local area. So it's not about ignoring any of the needs of the local area. In fact, we are very keen that the local members feel in control of the process because they are the local, they know the local area.
Just to be clear on the JSNA, what I meant was I meant getting the county officers to listen when there's planning applications going on. So when roads and that need building, that the county officers listen and come out and have a look at some of the developments that are going on.
Well, I can't speak about transport, but in terms of public health, for example, I was here in this building 2 weeks ago, at the planning inspectors' sessions, you know, we do listen and we are trying within the resources we have to address this. I'm very keen to work with the Borough Council on a whole range of issues from planning to leisure activities, and we do already. I would love to upscale them more.
Councillor Gondigal.
Yeah, I just want to come back on that point you were making about the involvement in planning and transport. The fact that you're not involved in the transport bit of planning is appalling, because you do all this good research and say you've got all these people with health issues, and then the transport planners aren't taking any notice. We had an application at planning last night, 453 houses, no air quality assessment, with all the traffic going for the old Hinkley Road one-way system. We do need to get health assessments and air quality assessments for these large applications, because they do put a massive strain on the infrastructure, and particularly air pollution. We mentioned smoking. Smoking is about 3 times worse than air pollution. But air pollution is killing loads of people. And as we get less people smoking, as the education on smoking gets better, we still need to look at the other major causes of premature death and poor outcomes for people when they're born, the asthmas, etc. So to say, well, yes, we've done a good job, but they're transport planners and they don't listen to me, we need to change that.
I never said that.
No, but
and in
it's an
fact,
area we need
sorry,
to...
can I answer this? Because, you know, Councillor Condricourt knows that we are doing all we can. This is where you, as the planning authority, need to take more control.
I have written to the county planners as asked by this committee, and that will have gone on.
Chair, can I just say, in fairness, and you know, we've tried to encourage the county and others within the planning system to give us properly formulated reasons for what they ask for, and on some occasions they've got no proper criteria, so then the planning officers here aren't able to implement that as much as they want to, because they have to be accountable for it. But in saying that, on a number of recent applications, there's been requests come for funding from the NHS, and particularly the George Eliot, in relation to supporting staffing needs. And it's not that long ago when officers were saying to us, well, you shouldn't be doing that, but I know of a couple recently where the conditions have included contributions towards that, even for bank staff. And, you know, there's nothing particularly sustainable about that. But I just want to make the point that it's actually not true to say that that people don't ask and don't get, because they have asked and they have got.
Thank you, Chair. I really want to close the loop on a few issues that we've raised in our meeting today. First of is in relation to engaging the public. And it was mentioned there that there were some events that weren't very well attended or potentially aren't. And I think it's really important that maybe it could be a briefing note to members, but it's really important to use the local council and local community groups to advertise these things.
Yeah.
So that, you know, there's no reason the Borough Council, you know, if you were to speak to the appropriate people at the Borough Council, they can tweet things out, or there's Facebook groups that, you know, local people use. And I think it's really about joining it up, because people are missing out on these opportunities. But one concern I've got, and I'm hoping that you'll be able to address this, is you've spoken today about how the SDP was going to run up to 2021 originally.
Well, yeah, so that was the time frame to plan.
So my concern is that we've also spoken about addressing themes, which means we're breaking up a whole document and looking at piecemeal. And what my concern is, in that period, you're having to get on with work. And I'm worried that I want to be sure that you're not delivering things that potentially haven't been consulted on. And second of all, I really want a time frame of when you're going to develop the document. And I think it would really help us as members, not that you give it us today, but in the coming weeks or months, that you publish something for the public, for local authority members and others, so that we know how we can engage and that your process is robust, so that you're going to have these documents produced by then, and then people are going to be able to comment. Because what my concern is, if you break it down, and it's great to engage people initially, but if you break it down too much, you don't assess the impact of the whole. And we've got to look at things holistically, and you've got to have a document or a policy that has ownership by local people. So I'm just, while I appreciate you can't give me deadlines today, is it possible that you could come back to us, not necessarily physically, but with a written document or something in the future that outlines clearly what your development process is?
Yeah, okay.
Sort of timetable.
I mean, I don't, or I haven't to this day envisioned that we rewrite an STP in terms of, but we can certainly do something that updates the work streams we're saying, because they have developed a bit. I talked about the main ones, but there's some supporting ones. And so, for example, I didn't mention cancer services, which comes under palliative care, which is a massive topic in its own. So we could identify where we got to and what we're aiming to look at. And what I'll say is that the different work streams will work at different paces for different reasons. One, because some of the need is urgent, more urgent to get on and crack it. You know, we've got to do things around urgent emergency care before next winter comes again. We haven't got this one yet, so things like that. Women and children might be different now, prevention's a different one. So, yeah, so it'd be difficult to say that by X date, Y date, Z day, these things have occurred, but we could update where all the work streams are and say what we expect to do. So for example, I know in mental health, they're looking at doing something in the next 3 to 4 months, so we can have some thoughts about stuff in September, October, so we could do that, yeah. Just
one final question then, Chair, sorry. Just so I understand, because there's been a kind of theme through our entire meeting about the STP that was submitted.
Yep.
So you are currently working from that document then? So that document has kind of been finalised without...
I loosely at best. But what that did, you know, well, to me, what all that ever was a line in the sand that just said there are these areas we know we need to do better at, for a whole reason, a number of reasons, whether it's that little variation in life expectancy, because we know there's challenges around paediatric workforce. And at the same time, it identified, to the best of our knowledge is at that point, around what financial funding would look like and cost would look like, what the gap would be. And frankly, I haven't looked at that report since then, in read that, because I haven't needed to. We've moved on from that. We have developed some of those work streams. We've added new ones in. So that document was at a point in time. And it was done, and I said this earlier, the process was not a great process, but it was just a start point of where we need to move on things. And that's all it was to me.
I think, Councillor, though, you absolutely hit the nail on the head in terms of some of the work that we're doing around getting the engagement better going forward. So, again, because some people will think that that's the document and is the end product and we're going to deliver everything against that, we do need to get out and do some more engagement and conversations with the public about this. And one of the areas that we've looked at in terms of some of the lessons learned that we've picked up is, and we're just refreshing the engagement approach and the communications approach to, we've brought all of our communications officers across the patch together to say how do we get something that's understandable by everybody. So we've got our comms and engagement team working on that. We've got a new proposed approach that is, one of the themes is how do we work better with local councillors, because again you suggested some points about how we could work and use local councillors. And we're planning to use the Centre for Public Scrutiny to come and actually run a workshop for us. It'll probably be a one-off workshop, it may be in one of the areas, but our thoughts are to do that in June once the local elections are all completed for everybody, and we'll get some dates circulated though, so irrespective of the outcome of that, we can let people know and they can come and get involved. So we'll get that, we're finalising some details on that, but that was a key thing that's come through many of our engagements with local councils, is we need to make better effect actually of your doorstep conversations and knowledge, as well as ability to tweet stuff that perhaps we can't. So in your words, so we are pulling that together, and our expectation would be that by June we can have the conversations to just test out, have we got this right, these are some of the proposals about having the conversations. My own view is I think we need a discussion with the public about what do you want care to look like in 10 years' time? Because it looks like we're going to get a longer term approach to funding in the NHS. Hoorah. Who knows, but hoorah if they do that. It's looking like Jeremy Hunt's making some sense of the health and social care funding elements, as Andy has said. And actually that will give us an opportunity, but we need to start to be ready for that, don't we? So if we can start some of that further engagement from about June, I think that'll maybe give us a better chance of satisfying your needs and also your representative and democracy in terms of local people.
This is just the whole issue about planning, long-term funding, etc.
Yeah.
The health service has been hamstrung for years by political cycles. Normally, national government cycles, of course, and everyone wants to keep on to their seat, etc. The idea of having some kind of certainty over what funding will look like would make a massive, I can tell you how big a difference would, so we can think about what the future looks like for health service. And that is a completely apolitical comment. So I don't care what colour the Secretary of State is, if we can get that kind of decision from Treasury, it'd be fantastic.
Councillor Phillips.
Well, I care what colour this Treasury is, obvious.
You may, as a public servant, I don't make such comments then.
So, just this funding that we're talking about, you said there was a gap of 267 million. At
That point in time.
And we're looking at long-term funding, or we're hoping for long-term funding. But what about the short term? How does this funding gap affect us in the next couple of years?
In a big way, actually. But let me just go and clarify. The 267 wasn't about cuts, it's about we thought we'd spend more than we'd get if we just did things all the same way. The NHS has been, I use these words carefully, relatively lucky in terms of its resources being given over recent years. It's been ring-fenced in terms of real terms growth. But that has meant growth of circa 2% per annum during this terms of austerity, where historically from 1948, when the NHS was created, costs and funding have risen at 4% per annum. So it's still quite a lot below. But relatively speaking, to the rest of the government spending departments, we've been fairly well looked after. However, we are seeing increasing deficits across the NHS. Most of those deficits are coming home to roost in acute hospitals. So if we look at the financial year that's just finished and the year just gone, we have significant debt at the George Eliot deficit. We have a deficit in my hospital. Warwick Hospital has just about broken even, but it's teetering. That is reflected across the whole country.
But with respect, Andy, many of these hospitals, ours included, have got that debt because they were, as Chris said, they were historically underfunded in the first place.
I don't think that is evidenced, because that's not the way the funding of health service works. There are hospitals and healthcare facilities in parts of the country that are even further below their fair share that are not in deficit. There's a myriad of reasons, and so I think it would be wrong, in my opinion, to pin deficits of hospitals based on what funding goes to their local authority. There is that is part of it, but I wouldn't say that was the largest reason at all.
What would you say was the reason?
Staffing challenges, I mentioned that earlier. It's by far the single biggest issue. And the other challenge is what we are facing in the NHS within the funding regime is actually not how much money goes into the health service or past the health service, it's how that money flows around the system. So we have something called a national tariff, which was designed 10, 15 years ago and worked fabulously for a while. The tariff has not kept up with cost pressures in different areas. So we know that those hospitals, such as my hospital, University Hospital in particular, but not some across as much, who do specialist work, the funding for that is not keeping up with costs. We know this is where health service is different to almost any other industry. As technology comes into most industries, it leads to greater productivity. That's not true in the short term in healthcare, because as you get more technology, better drugs, better equipment, whether it be robotic surgery, it adds costs in the short term. And not understandably so, patients want the latest thing. And so the tariff for specialist work hasn't kept up to date with what the cost structure is, and we are talking about differential. So that's the major driver, I would say. The tariff itself into hospitals is not equitable as it was.
So just to go back to the beginning then, where does this 267 million funding gap, where does that leave us over the next couple of years?
The way it was modelled, by far the largest gaps were in years 3, 4 and 5. You'd expect that because it's a cumulative gap if we don't do things differently. You could say that if you took the cumulative deficits for all the NHS organisations as being the proxy for this gap now, it's about 50 million in contribution. It's not that much. Yeah, it's about 50 million. But that's on 1.3 billion. So whilst that 50 million is sounds a massive figure, you've got to think about how do you just make some differences at the margins, at the edges, to just chip away at that. One of the great things about, whether we liked it or not, the plan we submitted in October 16, is that when we looked at how we could cover that 267 million, there was no big, do this, it's going to save 100 million. Because that's just kidding yourself. There was lots of different areas. If you look at this, you might save 2 here, 5 million there. And it's those things that we're tracking that through now.
And some of that was the health service year on year has to make efficiencies. So doing more for either the same amount of money or doing...
The NHS's productivity is considered to be the most productive healthcare system in the world if you look at independent studies by the Commonwealth Fund again. If you look at the productivity of the NHS compared to the British economy, it's twice the rest. So the productivity of our economy is about 1 to 1.5%. If you look at GDP over the last 10 years, the health service is 2.7%. So we've got it, but because it's more difficult, each and every year it's more difficult. So that's what we're trying to do. I've talked about, there's loads of duplications in health and social care we need to get rid of.
And waste in terms of delays, having different types of provision. We delay handing one patient over from one service to the other. And that's partly where the integration agenda, we need to get much smarter at that. So A, we're not wasting the patient's time and the carer's time, and B, we're not creating extra cost and duplication in the system. So that's...
In terms of duplication, can you give me some examples of that?
No, I gave an example earlier. How many people do you need to make an assessment of what somebody's needs are? Why does a local authority, I'm not saying this necessarily in the case of country Warwickshire, but this is classic in the NHS. We'll have physiotherapists and occupational therapists in the hospital say, this is what this patient needs for them to go home or to a different care setting. Then you ask someone from the local authority, occupational therapists and physiotherapists, come in and make the same decision, or it might be slightly different. But why do you need 2? Why can't you just trust one?
Well, years ago we just had a medical social worker that did all that.
And
so I don't know why we're reinventing the wheel constantly.
I wouldn't necessarily say we go back to but some things in the past we can learn from. We've closed lots of nursing home care homes, which may cost £100 a day to put a patient in. To keep them in a place like mine is £350 a day. But that's crazy. So we need to think about where we invest money to save it. Because that's the other thing. When we come on to stroke services, actually this is about investment in services locally. That will actually will have a short-term cost, but the longer-term healthy economics of it are massive saving. So we've got to make some tough decisions like that as well.
We can only do that together. That's partly why we need to make the most of this partnership in terms of the STP partnership bit of it. Because that is then, if we're looking forward at sharing a single plan, having a single control total so that we are improving the position, but we agree that across all the partners rather than having bits of the system that agree the numbers.
I agree with that,
helps us
but
that integration.
The CCGs were meant to be medically led, weren't they?
Yeah, they are, yeah.
And it just feels like it's all gone pear-shaped since the introduction of CCGs.
Oh, right, okay. So, I mean, there's some local defence of that I have to say, so...
Not personal?
Yeah, no, I think CCGs are definitely medically led, and locally we have Derek Stevens, who's the chair of the CCG, and elected GPs on there that make sure any of our decisions are... We have a majority of clinical leaders on the governing body, as well as me as a non-clinician, as the accountable officer. So they're definitely clinically led. They do make different decisions than perhaps the historical position. Locally, because you've had a CCG, and councillors will have heard me say this before, we actually have gained resources in this area specifically because of our distance from target. So in the past that probably got a bit diluted in terms of actually across the whole of Coventry and Warwickshire it was potentially not as exposed, but because we've got that exposure, our pace of change and the funding that's come in has been faster than it would have been previously, although it's not got there, as colleagues were mentioning.
In terms particularly of mental health, it doesn't feel like we're just getting anywhere with it.
Yeah, and it's probably worth bringing an update on the mental health work that we're doing together, and maybe Sharon Binion coming and doing that to a future meeting just to do that. And again, there is the event on Thursday where we're covering off, I'm sure the topic's mental health.
Well, we've had someone, haven't we, Jill,
Yeah.
for mental health, and it comes up again and again, the lack of beds, lack of inpatient beds.
Right, okay. So again, that is the partnership trust that we need to talk to about that. So
I'm no expert on mental health, you need to hear, but that's a really interesting observation because nationally, inpatient beds is not the issue with mental health. It's actually about having local services that are reactive and proactive to local needs at local communities.
We've got those, we've had them here, Andy, we've had people who do that, and they keep saying, okay, they can treat so many people in the community, but there are people who cannot be treated.
Oh yeah, absolutely, yeah, I get that.
And they've nowhere to send them.
Well,
and that's probably the more
That's
specialist beds.
it must be the real more specialist, because I know, for example, on my hospital side, we've got the Calvin Centre, and that's half empty at the minute. But it's probably more the specialist, like children and adolescent beds, isn't it? It's a challenge.
That is a challenge.
I mentioned earlier, I mentioned about having 10 adults in my emergency observation beds at the moment, which I'm not used to. I've got 2 children who really shouldn't be in my hospital. They're safe. They shouldn't be in a specialist bed. Yeah, and we're on top of that. I think that's right.
And it's like Bill mentioned, care in the community, making sure that people take medication and things like that as well.
I've got 2 speakers. I've got Councillor Brindley Edwards and Councillor Condicore. I've got a couple myself, and I have noticed that the Cabinet Member for Houses at the back who has indicated, and as long as he promises to keep it brief, I will allow him to speak.
Can I just ask one question before everybody else
Very
speaks?
succinct, Chair.
What time is the Rockwell car park close?
7 o'clock.
7, okay. That's when I park my car. And I didn't check before I came.
Except some of it's for the gym now, so that's later.
Well,
1 and 2.
Oh, 1 and 2, that's all right. Oh, I've got no excuse now.
Don't worry, it opens in the morning. We're not going to let you.
If it's before 5:30, I'll leave home then. Okay. Yeah, sorry.
So, Councillor Brindley.
Thanks, Chair. I don't have any questions as such, just a couple of points that I'd like to make. Councillor Hancock's earlier on made the point about change and the fact that NHS is constantly experiencing changes, and I don't think it's necessarily a bad thing. I think an organisation like the NHS, it has to change because the needs of the population, the context that an organisation like that is working in, the demographics are constantly changing, and without that change you're not going to be able to provide the best care, which I'm hoping is ultimately what this STP is about. And okay, some of it might be to do with efficiency, might be related to some cuts, and we've talked a lot about deficits, but you know, there's 2 different strands to a deficit. Part of it might be underfunding, but the other way that you can get into a deficit is by overspending. And I think for that reason, some efficiency savings might have to be made, but ultimately it's about improving standards and being able to provide that care and being able to provide the best care. I mean, I know it's called, is it Better Health, Better Care now, but it's not just about constantly being better, it's about trying to be the best. And the second point that I'd just like to pick up on is that a few members have commented about local representation or lack of for our area. But we actually have more representation than perhaps some realise. There's a joint overview and scrutiny panel set up at Warwickshire County Council that was set up specifically to scrutinise the emerging SCP, which Councillor Golby actually sits on, and it's something that she feels really passionately about. George Eliot Hospital is in her ward, and I have every faith that she is representing the views of Nuneaton and Bedworth and making sure that, you know, our local residents are going to be looked after. Yes.
Just on your first point, So at UHCW, we're one of the 5 NHS organisations who have been partnered with an organisation called Virginia Mason. It's a hospital from Seattle in Northwest America, whose reputation is, if not one of the safest, it's the safest hospital in the whole of America. And when we think of that so we're very lucky to partner with that. We're 2.5 years into a 5-year programme. Gary Kaplan is the CEO of Virginia Mason, has been for about 17 years. He has a saying that basically the path to low cost healthcare is the same path to high quality healthcare. So you get things right the first time, it's cheaper, it's better for patients, and it's cheaper for the public purse. And that's what we're trying to do, is eradicate waste at all times and duplication. And you are right, some overspending is due to, you should be by the way you spend money, and local authorities have been faced that for a while, haven't you? So I agree with that. And I can't say, but yeah, I've heard her speak very passionately.
Just a quick point, you mentioned there's some communication event in June and you're talking about communication strategy. When are we going to actually see on the parochial local level the sort of emerging ideas on A&E and maternity? Because you mentioned maternity earlier, but we haven't really know when we know what the emerging ideas are. Obviously, you're saying you're not deciding on things to consult, but it'd be nice to know what you're thinking.
Yeah, we can, again, what we can do is bring out, we'll run our People's Commission. If people can come to that, that would be the place in this area where we will have the conversations about the emerging thinking on themes. And if I don't know, if a couple of councillors are there on Thursday, we can ask for maybe emergency to come up as a next time. We're certainly not in a space that says what would be any impacts locally. We haven't got to that stage on any of the other themes as far as I'm aware. Maybe the upscaling prevention might be a next one in terms of some local flavours, John, that we could talk about. But we can do the emergency and urgent care one.
Prevention.
Yeah, the prevention theme.
Which we're in the process. Sorry. So the upscaling prevention programme is the part of the Better Health, Better Care, Better Value (STP) programme that focuses on the issues you've been talking about, on reducing demand, on making people healthier. And it's a single programme across Coventry and Warwickshire. It's not anything new. It's about upscaling or the work we're already doing across a number of areas and giving more focus. But as part of that, we've had support from the Local Government Association, and the County Council and City Council have allocated additional resources, and we're hoping to designate next year, 2019, as a year of well-being across Coventry and Warwickshire, which the main purpose of which will be to draw attention to these issues, to show what is available, and to work with local communities on how we tackle some of these issues. And that's why the JSNA and the whole process of local profiles is so important, because that enables us to start discussions around needs in local areas. But the next meeting of the joint health and wellbeing boards across Coventry and Warwickshire will be looking at a plan, and that involves the health portfolio holders from each of the districts and boroughs. Yes, it does. Yes, it does. You were there, Councillor. Yes, you were.
Perhaps you can have this conversation.
Yes, I will. Sorry, Chair. I just donated what to the joint meetings, that's all.
So, if I can just add a couple of comments myself. I've got concern when you're mentioning about duplication in the terms of, we've been here before, in terms of the Manor Clinic, where it was duplicated naturally. Oh, and move everybody over to the Caledon Centre. It left relatives that were in the Caledon Centre with nobody to visit them, because actually they couldn't get there because there was no buses to get them there. They didn't have cars, or it could have been the car owner that was actually in the Caledon Centre. So I've been there before in terms of duplication. And, you know, why are you saying, oh, well, we don't want somebody doing the same thing? I have a horrible feeling that somewhere in this duplication will be lots of services to this borough. And as a member, that really, you know, that would not sit very well. When we've lost an awful lot of services already without actually using the word duplication. I do worry about your consultation, that it will be local consultation, not the other end of the borough. You know, because I know when we've had consultation before, there's been no consultation in Bedworth. You know, people from Bedworth couldn't get across to maybe a consultation that was in Nuneaton because there was no transport, or you've held them over in Coventry. So I think, yeah, that's something that really, if you want proper, meaningful consultation, that has got to be over the whole of the borough. And I'm talking Bedworth, Bulkington and Nuneaton. Because it just seemed very, very thing. I'd like to say I've understood the SDP or the better health, better care, better value some more, but I've got real concerns that there's an awful lot of work going on in the background, but actually as a borough, until this meeting, we've not been helped an awful lot. So, you know, in 2017 we wrote to you as a council, and I've got we resolved that we couldn't support or endorse the SDP because we didn't felt it was written in plain English. We were not happy with the clarity and detail around it. And actually that was at the 11th of the first 17. And actually this is really the first meaningful engagement we've had with this borough, which is a shame.
Just on that point about the language, I asked a question earlier. I said I wasn't being flippant, I haven't looked at the document really since we submitted it. I haven't. And one of the reasons is, again, we talk about the process being pretty poorly designed. I think I made my point around that. When we submitted that had to be submitted on Friday the 21st of October 2016. And the document we put in was just in a certain format, templates, and it was very clearly written in NHS speak, because it was going to NHS managers. We got a phone call literally like 2 or 3 days before, which saying, "Oh, can you make this a public-facing document?" Absolutely no chance. Because it was never it was never written to be a public-facing document. Because it was supposed to be that John Delaney understanding. And it was going on those 2 days, the Tuesday, Wednesday, Thursday of that week. It was going through all the constituent bodies, formal governing bodies or trust boards, to sign off. And it wasn't meant as a public sector. So your comments and observations about the document itself are absolutely correct. It probably came across a lot of gobbledygook to a lot of people, because it was never actually written for that purpose. And actually, so your earlier comment, perhaps now's the time to just put something on paper about where things are now, and not trying to do a 70-page document is really good.
It might be helpful, certainly for the members around this table, the residents out there, that we could actually see a document as to what you've added in, what you've taken away now.
Yeah.
And in plain English would be lovely.
Yeah, it would be. Yeah.
So almost a position of where we are from where we were.
Yeah, that can be done.
Yeah.
Councillor Longdon, as a health portfolio, you've been very patient and listened. If there's any comments you'd like to make that might enable the panel?
I'm absolutely agog, but I wouldn't like our visitors to leave thinking they got away with it totally. I think there are issues on the history of it. I'll start with that first. I mean, it's good of Andy to actually stand up there and sacrifice himself on the cross of responsibility. But in actual fact, what hasn't been said was the fact that this SDP was drawn up in absolute secrecy. Nobody was invited to make comment, nobody was invited to actually input into it. And when it was published on the 6th of December, it went to the press first. The press had it, or the media had it, the day before everybody else had it. And they drew conclusions from it. Everybody else drew conclusions, because it was written in Chinese as far as anybody could see. And where there are gaps, or where there were people reading things and gaps, people made it up and filled it all in. And because there was no immediate retractions, people thought that was the truth. And it went on for a considerable time, and I think it was quite legitimate. Local authorities were then asked to endorse it, or about a week afterwards, were asked to endorse the SDP, and nobody did. I'm not sure about Stratford. I think they went to ground. I think they went into hide in Stratford and Warwick. I'm not sure exactly what they did, but all the other local authorities condemned the SDP, including us, and nobody actually endorsed it. and there's big criticisms about how it was drawn up and what it said and what it didn't say. So the whole thing really wasn't necessarily Andy's fault. I put a lot of the blame on NHS England. I blame them for everything. They certainly screwed up the campus idea at the hospital, which is now stalled because of stupid red tape, and I think NHS England are basically responsible for that as well. No? Well, that's what I believe. That's because I can't find any answers about why. And they cancelled the last meeting when I was going to ask the question, but I will still be of that opinion because that is my ilk, and when asked, that's exactly what I should say. In terms of the JNSA, we were presented at the Health and Wellbeing Board with a document which made an assumption that all local authorities would pick up the lead role for the JSNA. When we checked with the pilot area, which would happen to be North Warwickshire, we found out that it was resource intensive and we couldn't do it. And I said, no, we can't do it, and said that at the Health and Wellbeing Board. Izzy Second was not best pleased. She stamped her feet a little bit. But things have moved on slightly from there, and we are talking in terms of what we might be able to do. But my argument as well with John was that the issues that we've got in terms of health inequalities, which are massive, and the problems of mortality, we already know about because these exercises have been run before. They weren't called joint strategic needs assessments in those days. And what happened when we found out where the problems were and what the problems were? Absolutely nothing. Absolutely nothing has happened and nothing changed. John's argument back to me was just because it's failed in the past doesn't mean to say it's going to fail in the future. Might be right. So I suspect the way things sit and the way funding sits, we're not going to see a very great deal. The hospital was very keen on this because they obviously want to tailor services to where the main problem areas are, and I don't blame them for that. And hopefully that will come out of this. But nothing else, I don't think. So I think that was my comments. I was just trying to level the playing field a little bit because it wasn't exactly portrayed in the way that it was.
Hopefully I've been very clear in my thoughts that the process was very flawed and poor. I've said that 2 or 3 times.
Yeah, I said thank you for that.
I've also said that it was really written in NHS speak and not a public facing document. The one thing I will just clarify is, that the publication date was planned to be Monday the 6th of December 2016. It wasn't given to the media. It was leaked to the media by a member of a local authority. I know who it was. I'm not going to say who it was, but I know who it was. It was shared. I know it wasn't. It was shared with several key members of the local authorities across country in Warwickshire the week before, in confidence, for questions to be asked before it hit the streets and the media. Unfortunately, somebody chose to leak it.
I say I didn't have it before the media got it, but if I had it, I would have done it anyway.
Thank you for your comments. Thank you very much for your time. If we can get the things we've asked for,
yes, we'll do that,
would
absolutely.
be useful. And I'm sure we'll be calling on you again.
No, it'd be my pleasure to come along.
It was nice to see you eventually. So move on to Andrea.
Okay. Thank you, Chair. I am aware of time and I don't know how long people have got, but this is a follow-up and update in terms of where we are around our planning improvements for stroke care. And it's a really good time to come back to you because we're just on the edge of submitting our proposals for consideration by NHS England. So what, first and foremost, one of the things we wanted to make sure everybody was aware of was the number of people involved in developing these proposals. So I'm going to start with, thank you, that might confuse me. Just in terms of the list of our local Oh, GPs. Our local GPs have been involved from my chair in the CCG in terms of general practice. We've also had James Abuji as the stroke physician and the lead on stroke care over at George Eliot. We also had Gordon Wood as the previous medical director was involved and has been working with us since we started the work back in 2014. So this isn't what you're seeing as a result of work since 2014. We've then had a number of the specialists, and again some of these came and presented the proposals to the Joint Scrutiny Committee that Councillor Brindley Evans mentioned earlier. And again, that was just proving this isn't just me presenting these proposals, but that was a whole clinical team across all of the providers, both the community, the acute trusts in each of the areas, the specialist rehabilitation teams, our public health colleagues, senior nurses and leads for stroke service and coordination across the piece. They all came and presented the proposals in terms of where we've got up to in a longer presentation than I'm going to do this evening, but I've tried to pull out some key points for you to sensitise this to local people, but that was key. The other thing that we've heard since doing some of the recent engagement as well is people want us to be talking about this is not just improving stroke care, this is about getting a pathway of excellence, was the language that colleagues felt might be more effective in communicating what we were trying to do. So if we, pressing the wrong button, let's have a go. There we go. So the reason that we decided we wanted to improve stroke care, and again you'll have seen from the engagement document that came last time, we know that we've got a gap between very best practice, this Midlands and East service standard and specification, and what service we offer at the moment in terms of our local population. We know that some of our patients, more of our patients, could benefit from an assessment in the hyperacute, the very specialist part of the stroke service. And the evidence, the new evidence that came out that started us looking at this, originally was that you need to be there within 4 to 6 hours because stroke assessment and care is critical in that really a very short period of time. But there was further evidence that came out that said actually you will get a better outcome if you're assessed in that sort of centre with all the right equipment, with the specialists who can look after you. They need to be people who are seeing at least 600 people a year who are stroking to get the best outcomes, which again meant actually the hyperacute unit we've got at UHCW, needed to be bigger because we needed more people to go through, but actually we needed a centralised service for that service to be able to operate for everybody because of that 600 patients a minimum who need to go through to keep the skills up, the competencies, and also have all the kit and everything around. So we've got a gap at the moment. Some of our patients are going to George Eliot who are within that 72-hour window, and the future we need that not to happen to get the best outcomes. So our service is not configured optimally. We have had trouble recruiting stroke specialist consultants. There is a type of consultant who has the right regular specialist upgrades and training that's defined by the British Association of Stroke Specialists, and we haven't got enough now. We need to recruit them, but we're also struggling to recruit because there's a national shortage, and actually the stroke physicians who are there are making decisions to come where there are pathways of excellence, and ours wasn't. So if we express it like that. We had an inequity in terms of the specialist rehab, and so again we've got patients in hospital beds far too long. This area currently has no specialist stroke rehab, so we knew we'd got a gap there. Other areas we have got some specialist stroke rehab, but this was an area that has none of that. So none of our patients were benefiting from that, and we needed to improve services for that. One of the other things is that actually, because time is critical, and they talk about brain being critical, because actually the longer you leave it, the more likely you are to get impairments of brain and function and or potentially death, then actually the patients who live closer to a hyperacute unit than UHCW, so we do have some actually just in the north where they're closer to the Heart of England Foundation Trust, and then in the south, very small numbers though. But actually where the journey time is critical, the patients will go to wherever is the right place for them. But obviously those were the key reasons that we wanted to make improvements, to try and address the inequity that already exists, and also we're not delivering optimum service and best practice. And I'm now not managing to do that. Oh, there we go. So, our proposals are about reducing mortality and disability after the stroke. So these changes will offer the best evidence-based care for that hyperacute and the acute period. What we'll also do is take anybody who has what's called a mimic of a stroke, because some of the symptoms can mimic a stroke even though they're not. And again, the assessment in hyperacute is a really important assessment to exclude that this is a stroke that's happening. So what we want to do is do that. We want to get equitable specialist rehab for the majority, and that rehab will be at home for 70% of the population. So the majority of people will go in, spend a shorter time in the acute hospital, but then come home and they'll have a rehabilitation package at home with the specialist team. And also the other issue is trying to improve the workforce and get a sustainable workforce. By having a pathway of excellence across the whole of Coventry and Warwickshire, and getting the doctors, the nurses, the therapists working together as a single team, even though they may be employed by different providers, we've actually got an offer here where our proposals will help us to sustain that team and to build that excellence that we want. They also want to start to look at, again, that continual improvement and doing some research on stroke, so the opportunity is there to do that. I wanted just to update on the engagement that we've done. So we've talked a lot tonight about how we're talking to people and engaging them in the proposals, but we've done a number of things and our proposals have changed over the period of this engagement. So I think that is also critical, because we talked earlier about evidence locally about consultation perhaps is not being considered, the decisions made before. Actually, we've done all this engagement. We haven't yet made a decision, but we have got to a stage where we've got some pre-consultation proposals that are ready. So the engagement we did was, the first part was going out to all of the local stroke groups that we have. I think we've got about 6 or 7 in this area that I went to personally 2 or 3 times to talk to about, we were thinking of improving things and talking to them about this in terms of an offer, that the things that are in the box. So we gave them some of the evidence and said, what would you think if we were, and we were only at that time thinking about the acute hospital bit. So, you know, if we did nothing, we left things as they are. If we centralised the hyperacute and the acute services, and then we talked about 2 different ways of delivering the other services, working with the George Eliot and or Swift, so there were different alternatives in terms of where people spent time. What was really clear from that engagement, and we took about 12 months to get the information back from those groups, and this was done in all the areas, not only this area. We also talked to some of our inequalities groups and others. But from that, they were really clear that actually we could not just think about acute care. They wanted us to look at the rehabilitation services, because again, they raised the issue of the gaps in rehab that we've got. And they also wanted us to look at actually stopping strokes, because they thought the preventative agenda wasn't covered either, and that actually we should go away and rethink how we did that. So the outcome of the 14-15 work was very much go away and think about a broader pathway of care and getting the pathway right. So we looked at some proposals around preventing more strokes, and we also looked at how do we get the rehabilitation added in. And this is where actually partly we started to come out with the extra investments that Andy mentioned earlier. This one is that. So we expanded the proposals. We piloted some of the rehab in the Coventry area to see actually can we test it and see if it was working. We did it in Coventry at that time because Coventry got the money to invest and we hadn't got funding locally to invest. So we piloted it there. We got the senior clinicians to look at the clinical assessment and the options for deliverability. So actually having heard what the public were then saying about this whole pathway, not just an element, what would be clinically able to get delivered in terms of workforce and service. So, you know, practical, is it doable? And they actually then at that time came back to us with just really that one option that we then went out and engaged the public on again in 2017. So the main constraint was from the clinicians was actually the specialist workforce to get this done if we did it in any other way. So we did the engagement during June and July. We did some of the local consultation process, and we did target Bedworth in terms of a public meeting, as well as using other engagement methods. But I hear the messages that were mentioned earlier about we need to get out into the 3 areas at least to make sure we get comprehensive views back. We also at that time commissioned something called an independent integrated impact assessment. So we heard earlier about, are we impact assessing things for equality? Well, we looked at equality, travel and inequalities in terms of impact. So that was it. The other element that we've done in terms of building the proposals so far was we had an expert patient group who've worked with us, and Rachel, who's on here, and her mum Sheila were part of that group. They live in North Warwickshire. It's not Nuneaton and Bedworth residents, but they've used local services. And we just thought it was worth you hearing their story in terms of the work they've done on the proposals and what their thoughts are. So it's only 4 minutes, 3-4 minutes, so I apologise for running on time. It's doing buffering now, that's called, isn't it?
I was working, I was a deputy head teacher. I had textbooks, so I was offering it to the class, and I had what I now know is a TIA, but it was gobbledygook out of my mouth. And the teaching assistant must have realised it was wrong. She went to the head teacher who knew it was a stroke. By the time I'd recovered, the ambulance was there, my blood pressure was normal, everything was fine. I had another TIA in George Eliot's A&E. I was rushed to Walsgrave. They decided to do onto the ward, the stroke ward, and I was talking with my mum, and I had a massive stroke, and I can't remember what happened next for about 3 days. We were very impressed with the fact that the stroke sister was monitoring Rachel every 15 minutes in the A&E. I was scared, and I thought if I went home, it would be okay. Well, if I'd gone home, I would now be dead. Yes, yeah, but luckily she was in the right place at the right time. The next 5 months I was in hospital. The next probably 2 to 3 years I was out of hospital and in community rehab. George Eliot was and is fabulous. But when I had the stroke, I went to Walsgrave. That was the best for me. And I would hope that it would be best for everybody. I personally think that you better to go where the expertise is. The Walsgrave, you have got all the equipment to do the testing and to see what's going on in the brain, because you can't visually see what's going on. Rachel felt very well after she had a second TIA, but they'd done scans on her and they could see what was going on inside. We feel that we've had a chance to influence what is going to happen because the people who conducted the meetings did listen to what we had to say. And as well as representing ourselves, we were representing people that we knew that had stroke, because each stroke is different. And it's better to have a uniformity all the way through to make sure that people get the best treatment they can get initially, because that influences the outcome of how you're going to recover from the stroke. Do you feel that? I would agree. Because we found on the rehab side, and speaking to people who had had strokes in Coventry, they didn't get the same rehab as we got in this area, and ours was better. So I think it's you know, you've got continuity of care, which is what you need when you're recovering from a stroke.
I would recommend being part of a patient group. I want my opinion to count, and I want other people to realise that your opinion matters.
Just after Rachel had finally started to be a bit more independent, last June my husband had a stroke. People who've got suspected stroke directly to UHCW to get the treatment they need. The expertise is there with the trained staff to be able to monitor and know what's going to be happening next. So I would definitely recommend the way forward that is proposed to centralise the hyperacute phase into HCW and then to the therapy, if necessary, to be taken forward in the homes or hospital to make sure that people recover as much as possible and not have the after effects of strokes that people have suffered in the past.
Hopefully I can just I know I need to get off and we can go to the next one. I'm going to now get security. But we can
We've got it on the paper as well.
there we go, yes, there we go. So, one of the things that I thought was really important was to bring back to you what we've done after the engagement and hearing the messages we had from your good selves, but also from others in terms of that engagement. So one of the areas of concern that people were saying about our proposals was capacity at UH to accommodate the new arrangements. So because we're talking about a bigger hyperacute unit and more people going through the front door, there were concerns in terms of people getting appropriately recognised in the emergency department and then pulled through as one of the issues. So could we cope with that extra demand? And it's unfortunate Andy's had to go, but the challenge is that two things really. The stroke team have come out with their future proposed method of pulling people through from the department in ED. The Trust have recently, in terms of UHCW, also put some improvements around ambulance handover in the emergency department that mean that you get a first assessment from the ambulance by the senior team. That has reduced the ambulance handovers. So again, most of these individuals would travel by ambulance as they're identified. So actually, we've got a system that they're assessed really quickly, and then the stroke team will pull them into the hyperacute unit. Usually the ambulance would ring ahead and say we've got a suspected stroke, and the hyperacute unit then send a nurse down into the department and will assess and pull people through from there. So the sense is, with those processes in place and the new rapid assessment service that the Trust have very recently put in, that actually there should be sufficient capacity in the emergency department. That was the key question, and with an expanded hyperacute area, that will help us on that. This rehabilitation at home, what people were concerned about was, we've seen all this before and you make the changes and actually we don't see the rehab at home. So there was a lack of confidence, in us getting the staff, with some of the comments, and I think the committee picked up on that. How will you get more staff, you know, because of the staff shortage? And also, how can we be confident in these proposals that you'll have those available? So one of the things in terms of us thinking about what we might do on that is our proposals now are about implementing the rehabilitation offer first, so that we can be demonstrating to people that actually we've put that service in before we then open the acute parts of the service change, so that at least people can be confident that we're pulling that 70% of patients and they're getting their care at home. So that's what the teams have said they want to do. So their plan is on implementing any proposals. They would need to do that piece of work first, and they're starting to do some detailed planning on how they get that workforce plan in place and the workforce attracted should we get through a public consultation. That'd be the way forward. But that was the way of dealing with those concerns, because again we do need to build public confidence, I think, in this. if you're going to do the change. The challenge around being less acute beds. So yes, we did talk about 92 beds now and moving to 43 co-located beds, so the hyperacute and the acute at Coventry. We'll have 39 specialist rehab beds, so the ward at George Eliot that's currently a stroke ward would convert into a specialist rehab beds. So local people here who are the more complex and can't go straight home with a package of care at home with the specialist would go into the George Eliot stroke rehab beds, so that will be the flow for local people. The expectation and the planning that we've done in the evidence says that will be around 30% of the people who stroke, because they'll have complex comorbidities. They may have situation at home means they can't go home with a package of care. There might be another vulnerable carer or other issues, but again, we've allowed a bigger percentage, so 30% of those to be able to flow locally to the George Eliot beds. And then this volume will be the 560 extra packages of care above what we've got now across the whole patch. So again, we are changing the 92 beds, but we're putting that other provision in. And if we can demonstrate to people that we've got the staff and we've got the rehab packages available, that should build confidence then in terms of the proposals there. The other bit that's in there actually is we haven't said about is the prevention elements. Our proposals also prevent 90 strokes a year. So again, that would mean that some people don't even have to start this journey because of some of the work we're doing on prevention. Another message we got actually from the Joint Scrutiny Committee when we presented this was we need to get a better prevention agenda sorted. So we've in here talked about looking at where people have atrial fibrillation, identifying it and making sure they get the right medications, because we've got some care gaps and some quality gaps at the moment. But actually the Joint Scrutiny Committee said you need to have a really good communications offer around prevention of strokes, and actually let's get some local education going and put that in the proposals as well. So we're building an offer around that too at the moment. Transport and access, as we talked earlier, lots of comments came back about access. And part of the integrated impact assessment that we commissioned looked specifically at the issues around health inequalities and determinants of health, travel and access, and then the equality issues per se. One of the things that we had to consider when we were looking at the proposals and thinking through, so what else can we do to finalise this? It was quite clear that there were some negative travel impacts for people around the proposed changes. However, the clinical evidence and the assessments that the impact assessment did said it was still right to do this centralising for a shorter length of time, but the right quality and standard of care, and then bringing people home, so getting the majority back. So it is a balance, but we actually think that that is still the right way forward and the right thing to do. We've got each of the actions that you'll see in here, and again, it's a shame that John's gone, but we absolutely need to pick up the transport issue and see what else we can do in terms of working with local colleagues on that. So again, we have a voluntary care scheme in Warwickshire. We know that isn't, from some of the review we did earlier in the year, that isn't known enough by people, so we'll need to working with John, get some more information, make sure that's publicised and people have that available. We need to make sure when people are and first go into stroke services that we give them and let them understand what the local travel options are. And so again, we've got a commitment that we will get information through to the stroke providers. So again, people can almost have a little package for the carers in terms of what the local elements are. But these are, and you'll see in the list, I'm not going to spend time on it, but the work that we're doing to build up, part of the offer is around transport and access and how can we mitigate some of that risk. The rehab beds in Rugby are probably not an issue for locally, and again the concerns about travel. We did go back and ask the clinical group to look at, having heard the concerns about travel, which mainly came from the Coventry area, who they would be travelling for their rehab, where currently they're at UHCW, they won't be there for that care longer term, so they would have further travel. We went back to the team and asked them if they could come out with a new clinical option. They couldn't come out with a viable clinical option. So unfortunately we can't, in the final pre-consultation business case that we're doing, that won't be, we'll have to say that. So, I've talked about what the schemes are, and we've done that here before, so I won't go through that again. The next steps for us are, we've finalised the pre-consultation business case, and that's currently with NHS England to review. So that is about extra investment. We have got a commitment across the whole of the health system, providers and commissioners, that we will put that investment in place. We are currently looking at how we get something that's realistic around that workforce. So they've already started to do some thinking about how they might get a workforce that's different. So that should NHS England assure us and say, actually, we've done everything that we can do before a consultation, because that's the process we have to go through legally, then our expectation is that we'll get a view in April, May on the outcome of that. And then potentially if they say, yes, we're ready for public consultation, you'll start to see more from us in June in terms of us starting that process. And what we have said is we'd like to try and plan for some joint scrutiny of that around the June time. But again, it's a bit early at the moment for local council colleagues who are going through elections. But we'll try and get onto their agenda in terms of that joint approach as early as we can. And again, Chair, I'd be happy to bring back an update here and obviously engage you in that process too. So, I'm sorry that was long after the rest of the length of the rest of the meeting, wasn't it? So.
Any member?
Yeah, I'm very pleased that there's an emphasis on stopping people having stroke at first instance. But obviously there's a delay between doing that preventative and the day they would have had a stroke. You don't do an intervention in the day before they have a stroke. It's a long-term programme.
Actually, some of the AF work could do that.
Great. Because one of the things I'd like to have some assurance on or some idea is, it's always wishful thinking, some of these reduction schemes.
Yeah.
Is there much tracking going on, and when does that sort of kick in?
Yeah, so again, it's a shame that John's gone, but what Public Health England have been doing with local public health teams have been building the evidence base around what works on prevention. Part of that modelling of atrial fibrillation and how if you anticoag people, give them the right meds, you can reduce the strokes. That evidence base is from our public health colleagues. So John's team have got all the information around what works as interventions around prevention of strokes. A lot of it is lifestyle, diet, smoking, you know, the key risk factors that we know already. You can either improve from where you are today, or you can change from where you are today, or you can stay exactly with the same level of risk factors. Part of the conversation and the information that, again, the Joint Scrutiny Committee have asked us to do is get some of that really easy to understand information out and available for people, not just recognising the symptoms. So that's what we'll be doing in terms of part of the proposals.
Councillor
Phillips. Can I just continue with that theme, Andrea?
Yes.
Because we just wondering how people will access that care that you've just mentioned.
In terms of the prevention of information. So we're just building up how we'll do that at the moment with John. So we will bring back, I think, hearing your messages about how you can help us to share the messages. I think we need to think that through. We will have a local programme for preventing illness in this area, and a theme of that will be around stroke. We were thinking about some public communications campaigns, so raising awareness, a bit like you see on the TV. We won't be doing TV advertising, we haven't got that money, but you know, the TV advert in terms of the symptoms, identifying the symptoms of stroke. But the lifestyle stuff, I think, you know, it is such a core of what your borough do in terms of trying to build up and get good cardiovascular health. We'll work with you to see.
Well, we try, but we've got about £10,000 to do all that preventive work.
Yes, so public health colleagues,
health officer.
Yeah, public health colleagues do work with us to try and make the most of that. But if we work, some of those things we talked about earlier with the STP, of actually, if we get the teams in the hospital saying the right things and giving people information, the teams in general practice, working with council colleagues to do the same. If we start to join that up, maybe the messages will get through better. But it is understanding, actually, technology is a big enabler these days in terms of some of that nudge theories and getting people to change lifestyle risks. So we just need to get a plan, I think, and then discuss it with local colleagues.
And just one more thing,
Yeah.
sorry Andrew. Have I understood this correctly? There's only going to be 2 rehab wards, one in Nuneaton and one in Leamington.
Yes, yeah.
That just doesn't seem enough, does it?
It is from the modelling and the forecasting that we've done in terms of looking at the demographic growth, looking at the reduction in strokes and then the complexity of the evidence around who will need those longer term beds. Some areas have gone down to a 10% of people who need that complex longer care. We're modelling 30% for our local demands. So we think there's some wriggle room in there if there is a problem. But our expectation and our evidence says that should be adequate for us.
But I wasn't thinking only in terms of numbers, I was thinking in terms of locations.
Oh,
As
well,
that being enough.
yes, that was part of the challenge that we had from Coventry residents and also Rugby residents in terms of them having to travel. They came out with really the main impacts are around their extra travel and how we manage and support that. So that's part of the travel plans that we're going to have to come as part of the proposals when we get to consultation. We'll need to do that. But so that yes, the impacts are that there are some negative travel impacts, but the benefits of the improved care outweigh those. So.
Thank you, Chair. First of all, to pick up on the travel issue,
Yes.
you know, for the last decade and a half at least, if not longer, I've argued to colleagues and partner agencies and stakeholders, not just here at the council, but in other work that I've done across the sub-region. I would like to see Warwickshire join the Centro region.
Yes.
And the point that I would make on that, whether it's the Centro region or a different mechanism, I agree with the point made that we need to have more bus services. So we need to have connectivity between all of these facilities and local residents.
Yeah.
But equally, it needs to be affordable. And that's the other part of the problem, is that, you know, if you're going from Nuneaton to Coventry, you've got to get a bus from here to Coventry. You're paying a small fortune for that. And then you've got to pay again to go from the centre of Coventry out. And it is really expensive. So affordability is an important issue in relation to that travel dilemma. I want to offer a bit of candour in relation to this plan. And while this might be really good, and it may be that actually this turns out to be very successful, I, as a local resident, am deeply concerned, and I've got a fear that we will see services at George Eliot like this and others go to UCHW, and it's a shame Andy and John aren't here, and I'm sure we can send them a link to the video. But I've got a deep concern that at the cost of PFI at the hospital and the overheads at the hospital in relation to the business case of delivering services really comes into play in thinking of where you're going to locate the experts. So it's great that you've got the experts and a team of people, and obviously if they were located at Nuneaton, people in the south would be unhappy, and so Coventry does make some sense. But I do have a concern that there is that downward pressure of overhead costs. So I wanted to ask you that really to give me confidence in that, is this decision being led by those costs, or is it all led by evidence?
So the decision is being led by the evidence. The cost of the PFI is neither here nor there. The evidence suggests that you could not operate this hyperacute and acute service at George Eliot or at Warwick because they don't have the co-located services. So things like interventional radiology. George Eliot's too small a hospital, as is Warwick, to offer those services. Their emergency departments haven't got the specialists that UHCW have because they're that specialist type hospital. So this is all about the evidence base of needing to get the volume of people up in there, having the right people around, having the right interconnectivity with other things like the radiology, specialist radiology. You know, there's new stroke services that are coming as well that will be about actually in future going into people's vessels in their brains and pulling the blocks out with neuroradiologists and skills like that. You could never do that in a small local hospital. So it's all evidence-based and the science in terms of where's the right location for the hyperacute. I can absolutely assure you of that.
The final question is, because we've spoken a lot about people using public transport, yes. And it was raised that there will be more parking spaces potentially.
Yes.
Although that's a matter for another, that's a matter for Coventry City Council.
Yes.
Obviously there are costs as well for people travelling over there and parking. Yeah. What could or might be put in place for people who just couldn't afford, family members who potentially couldn't afford to look after somebody and provide? I didn't know whether there was any consideration of how we could offer assistance to people to make sure that, you know, they can see their loved ones, or if they're providing care in the hospital, which benefits the hospital. And I'm not asking for the answer today.
No.
I'm just saying if you could consider that, because that's really part of diversity.
Yes.
It isn't always that diversity and equality is just about various characteristics.
No.
It's about diversity in economics and
absolutely.
That kind of thing.
So part of the, and I haven't done the detail just for time really, but part of the integrated impact assessment that we did, there were 2 actions around vulnerability of individuals, and so carers in this respect can be vulnerable because of affordability and economics, as well as being vulnerable because of their ability to travel and their functional ability. So the 2 bits of work that we're doing on our vulnerable population, which actually isn't just carers for stroke, it's carers for a whole range of things where they have to travel around. That was one of the things that came through for us when we were thinking about the proposals. We couldn't come out with something just for stroke carers. We needed to think about vulnerable travel for all carers and or others. So we're working with John's team, Public Health, to look at actually can we come out with some better access policies around that. We have, colleagues gave us an offer to look at, you know, some of that might be subsidised travel, some of it might be other ways of doing it. The challenge we've got is you've heard about our deficit, so the challenge for us is actually subsidising travel in that is a real challenge. However, we are looking at what we can do. The other thing we're doing is working with the combined authority, again around one of your earlier points. So I've met with the lead on transport in the combined authority to see if we can't do a Warwickshire policy on vulnerable transport, could we actually be part of the look that they're doing around their policy across all of the areas that are in. And I think Warwickshire would participate in that, so I made sure that that was doable. And we've given them the evidence to say, actually, these are the issues that local people have said to us are right for them and affect them. Can you include that in your policy? Because they do a lot better in some of the metropolitan areas than we do out in our local areas, don't they? So they've had all the information. I've met them once. Rachel's met them as well, our public health lead. We've given them the information and we're waiting to see what that draft policy looks like, to see if it's something we can work on. But we will be developing something locally. That's the work that John's
And so, because, I mean, I appreciate me sitting here and saying, I'd love to see us go into Centro is something, you know, could be decades off. And I appreciate trying to get extra bus services every half an hour may not stack up for local bus companies. But in the round, you're considering all of this, and it could be, you know, one other thing that I would like you to consider and come back to us on is looking maybe at a shuttle bus.
Yes.
Just between the Elliott and UHCW.
Yes.
I just want to be sure that people can get there and get back.
I agree. And there are a number of ways that actually, should Andy secure the new parking, that actually could allocate space for vulnerable and or other carers that's closest to the hospital, that is easier to access. You know, that there are a range of things that we might do. So we will definitely come back, and as part of, hopefully if we get to the public consultation, we'd want to come back and talk to you about that. So I'd expect you to ask me that question, and I'll try and make sure I've got some answers on that for when that happens.
Ingrid.
Thank you, Chair. Can you clarify for me, please, who are the members of your rehabilitation team who would see a patient at home?
So they will be. So who do you mean?
Well, you're
the
saying
SD
that
service.
Rehabilitating
Yes.
care will be at home.
Yes.
Who are the members
So they will be
of the team who will be visiting that patient at home?
So there will mainly be therapists. So a range of therapists, generally physiotherapists, are usually the leaders of the team, and they will be the ones that go in and provide care for the individuals. The ESD service, I haven't got all the information in my head, but we could give you what the pilot ESD service has got. They have some nursing input from the specialists in the hospital as well, but they're mainly therapy staff who do it in terms of the service at the moment.
And will they be coming from UCH, or will they be based in local hospitals?
They'll be locally based therapists, because again, one of the workforce challenges we identified in doing looking at what the proposals were that the majority of therapists are live locally and want to work locally, and generally work part-time. So if you're going to attract therapists, what you have to do is offer them that, really. So these would be locally based therapists who will be going in and out of homes within the Nuneaton and Bedworth area. The employer might be South Warwickshire FT or CWPT as providers, but that doesn't mean that they're not locally based.
And how will you go about staffing, the numbers of staff?
Yes, so we've got the teams are working on a workforce plan at the moment that looks at positive recruitment, that looks at some very targeted development of therapists going forward, working with universities. I haven't got all the details because they've only just started to think that through, in that they don't want to do too much work because we've got a public consultation to go through yet, but it's just thinking about if that is in there, then how will they deal with it is the bit they're doing at the moment. So they are coming out with a workforce approach and a workforce plan, and we will have to convince, these will be part of the questions that NHS England will ask us is, so I will take along my clinical specialist with me who would answer questions like that about how they would do that and how long it would take them to do. They need to be convinced as much as you will need to be convinced that we can run the service.
One last question.
Yes.
In the rehabilitation units,
Yes.
you will have a set number of beds.
Yes.
Will patients have a set limit of time in a bed in the unit? So like, you will have 6 weeks here and that will be it.
Yeah, so we plan on an average basis or a mean basis, but actually that doesn't mean that there aren't people who need longer and get longer. So the evidence at the moment in terms of the vast majority of people, say in the George Eliot beds, stay there 6 weeks, some stay a bit longer in terms of needing things in place in the community that they can't get. Some also wait while we're waiting to place people in a nursing home bed and getting that sorted. So there are some exceptions, and there won't be an absolute, you've been here 6 weeks, off you go. That isn't the way that it'll operate. That just isn't how the beds operate anyway.
So what I'm thinking about is,
so there's a planning
is the
parameter.
pressure on a family.
Yes.
If, you know, initially it's said, oh well, we'll have a bed for you for 6 weeks.
Yes.
And 6 weeks is over, and the family are thinking, well, he's not getting better or she's not getting better. What's going to happen?
Yeah, so what you want is it will depend on the individual's needs, really. If the needs are such that they can't be met in that unit, and we've got a demand for that bed for somebody who needs can't be met in that unit, then it would be as now in terms of if we want to get people to the right place for their care. So there would be some pressures in the system around that, but that will be very clearly shared with people. But it will be, this is a specialist stroke rehabilitation ward, and if somebody can't benefit from that rehabilitation any longer, then actually they will need to be somewhere else, wherever is the right place for them. So, but we do have obviously some of those delays at the moment, and they will be built into some of our future modelling. But we should have the complexity of the stroke through this model, doing it this way, should reduce any additional complexity and offer the best possible outcome. So we don't get people who are really disabled with strokes. There will still be some, because again, as you heard Rachel talk about, everybody's stroke's different. So, Councillor Watson.
I've got a few really. It's, one is who decides that an acute stroke has occurred. Did you say that it was the paramedic or the ambulance driver or something? And what provision is being made for the non-acute patients? So that's well, if you want to go through that.
Yeah, shall we do
yeah,
that?
Yeah,
so in terms of who identifies an acute stroke, it can be a number of people. So the stroke will be identified, yes, by paramedics on a protocol, because they use that at the moment in terms of strokes or mimic strokes. Emergency department at George Eliot, people can walk in or be brought in by their loved ones and turn up there. They will identify and then refer straight through to the hyperacute and get the emergency transport through. Hopefully, when we raise some awareness, the public will start to identify as well and their carers if they're having a stroke. So we'll get more identification. But at the moment, there's a specific test they go through, but that will, if it's in the last 4 to 6 hours, so that will be expanded and have a new protocol for the ambulance staff, so they know this is where you go if you're in this area and you have a stroke within 72 hours.
I think if you can call it an advantage in that a stroke is externally visible. So as long as you know what the signs are, infectious speech and movement and so on.
And what provisions?
For the non-acute, those who are not strokes. So the plan is that people will go to the hyperacute, and if they turn out to be this mimicking the symptoms, the decision at that point will be made, where's the best place for this individual. Obviously, if they're at significant risk, they'll be kept at Coventry to get their stabilisation and or care sorted. But if not, we will have a transport option in place that brings them back to their local hospital where it's best for them to be local and they don't need that specialist input. So the teams are working on protocols for those transfers back where it's needed. But quite often it can be, say, a transient ischemic attack, as we talked about in there, and sometimes they'll get assessed at UH, but then they'll come back and see whoever in 7 days or something, so they'll get their pathway sorted before they move on. Yeah.
And the other one really is, well, you just touched on it really, somebody's working on a protocol, so we are still working on this discharge protocol, I take it. So,
it's really gone.
It's gone up here, but I don't think it's been solved.
Right, okay, so we're working on it.
So are we still working with the local authority, and who else are you working with to make sure that the houses or the homes are okay for stroke patients? Well,
so that will be part of the assessment that's done with the carers when we know somebody's going home in the acute centre. So the assessment will be done while they're in the acute ward in terms of going home, and you have the therapy team who will work with the individual, their carers, and understand what they've got at home, and then take people home with the right package of care. So it will be seamless in terms of they actually, at the moment, the model we've got is that they're in-reaching and working on the ward and then taking people out to the
So that could be some duplication then, because we could already have them staff at the council.
Well, what we could do is just make sure that we're sharing your evidence and we've got the connections, because I think that was the issue before, wasn't it, councillors? People weren't talking to each other to understand what assessment had been done. But the assessments that you've done would be fabulous to feed into the team. So we need to think about that protocol of getting that link working with the team. So I'll talk to the lead on the developing work.
We might get there one day.
Yeah.
Didn't you? Your point on working with a combined authority, good luck on that one. Because if one person doesn't turn up, they'll turn up.
Right.
And then that's it.
Okay.
The shuttle bus, Sam, that was spoke about when Squag was going around, because I worked on Squag then, and all I was going to do was a shuttle bus. Just close the area down and shuttle everybody over to UHCW. So it all happened really, but there you go. And that's my questions. Thanks.
I know the members and dates, so thank you very much for your time.
Thank you.
I don't need to update on the sustainable transformation plan. We've done that one. I've got no update on the adult and social care. On to the forward plan, which is for information. The work programme, the back of the document. So that's the double binding that time. There's a few items on there, and I presume they will transfer over. I know the George Elliott in regard to the discharge protocol that has to come in June.
Where is it?
In June. The George Elliott Hospital update. The very back page, page 19.
Oh right, yeah, the last one.
So I know they said one coming in June, I think that's because of something they're doing. And in regard to the update you wished on ONS, I'm afraid I haven't got one. Oh yeah, and that was Sheffield, so I can't do an awful lot about that. That's the one to ask him. Councillor Concord.
Well, can I express our disappointment we don't know what's happened to scrutiny? We talked about the lack of consultation about the STP. We need a scrutiny function. We actually said last time we need to know how we're going to scrutinise things. There was various guesses at how we're going to scrutinise, so I think we do actually need to actually, yet again, actually put a recommend to resolve the meeting or whatever, that someone actually tells us what goes on, so that if we don't like it, we can actually ask for something different to happen, rather than it just rolling on and then we find that scrutiny is all merged into one giant committee. Or we do want some clarity on this, and we did ask last time. So it needs to be a recommendation to the management to tell us, or the cabinet to tell us what's happening.
I've got one other item with the committee's approval. Can I suggest that we send congratulations to the Healthy Living Network in regard to the Local Government Association Award in regard to the work they do in this borough? I've got no any other items after that. Thank you very much for your time.